Good morning, my lady.
Morning, my lady.
Morning, my lady.
Morning, my lady.
May I please report, my lady? Morning.
Morning, my lady.
Morning, my lady.
Nelisi, will you please place the matter on record?
Thank you, Judge. Today is the 1st of March, 2022, calling the matter of Life Esidimeni Inquest, case number I-001 of 2021. Thank you, Judge.
Thank you. Where are our evidence leaders? Mr. Late, Ms. Marriott, are we ready to proceed?
Morning, my lady. I'm sorry for the printer. Advocate Foster indicated she wants to lead her witness first this morning.
Oh, yes. Where is she now? Miss Foster?
As a court please, my lady, I'm present. And next to me is Dr. Lombard. He is ready to testify. To start his testimony.
Morning, my lady.
Good morning, Dr. Lombard. Nelisi, where can you... Oh, Mr. Late? You are muted. Okay.
My computer is slow to respond this morning.
Something is not right with your connection.
Yes, I'm going to start as soon as they start the leading of this, I'm going to move to another computer.
Okay, can we start then?
That's correct, ma'am.
Okay.
Just indicate for my colleagues that the clinical notes.
I can't hear anything.
The clinical notes of Dr. Lombard is page 396 of case line.
Okay, I don't know. Mr. Late says the clinical notes of Dr. Lombard are on page 396 case line.
That's correct, my lady.
Okay, thank you very much. Nelisiwa, you may proceed to administer the oath.
Thank you, Judge. Doctor, please state your full name and surname for the record.
Anton Dion Lombard.
Do you have any objections to taking the prescribed oath?
No.
Do you swear that the evidence about to give is the truth, the whole truth, and nothing but the truth?
Yes.
Please raise your right hand and say, "So help me God."
So help me God.
You are hereby sworn in. Thank you, Judge.
Thank you. Before we start, am I audible enough?
Yes.
Yes, my lady.
Okay, I had a problem. I didn't know whether it was from my side or not. I think it was Nelly Siwe when she was administering the oath. All right, you may proceed, Ms. Foster.
As court pleases, thank you, my lady. My lady, just for the benefit of the other colleagues in front of Dr. Lombard, there is documents. It's only Mortem, the opinion of the doctor and his clinical notes. That is the documents that's displayed in front of the witness, which I will lead him on. There's no other documents or notes in front of the witness.
We don't know. How do we know that? We must just accept what you are telling us. That's fine. Okay.
I hope that the court will accept what I'm saying. Otherwise, I can show it.
No problem.
Dr. Lombard, can you please put your qualifications on record?
I qualified as a medical doctor in 1987 with a degree MBCHB in Pretoria.
Yes.
You are a private practitioner in private practice, is that correct?
That's correct, since 1990.
Yes, court, where is your private practice?
It's in Erythema in the Cullinan district, east of Pretoria.
Yes.
Please tell the court, were you previously involved with Cullinan Care and Rehabilitation Centre?
That's correct. When I started my practice in 1990, today exactly 32 years ago on the 1st of March, I was also appointed district surgeon in the area. And being the district surgeons, one of our functions was medical officer at Cullinan Care and Rehabilitation, where we saw the patients on a daily basis, the inpatients and patients that were ill also. And after about 5 years...
just go slow, Doctor.
Okay, but
It's fine. No, you may proceed, but...
Okay. Can I proceed?
Yes, you saw patients on a daily basis at the CCRC. Continue.
Yeah, I saw the clinical evaluations of patients. We had all the hospital inpatients, and then we had a clinic in the morning. And we were 24 hours on call for the hospital.
okay.
Proceed, Ms. Foster.
Thank you, my lady. So this started in 1990, is that correct?
That's correct.
You later then applied for a post to be appointed as superintendent of CCRC, is that correct?
That's correct. There was a post available as the superintendent. It's now called the CEO of the hospital.
Yes.
And there was 2 applications, of which I fortunately got the position. So for the next 10 years, I was the CEO on a temporary basis. We had a 3/8 percentage position that I had to be there between 7 and 10 in the mornings, where I was the superintendent, and at the same time I was still the medical officer in charge.
In consultation, you informed me.
Mr. Continue.
During consultation, you informed me that you were appointed during 1995-1996 as the superintendent of CCRC. Is that correct?
About that time, yes.
Yes.
During your tenure at the superintendent of CCRC, can you please tell the court, give the court an overview of how many patients were there, or CCRC in general?
We had approximately 400 patients and basically the same amount of personnel. 70% of the patients were severely mentally retarded, and we had
You had approximately 400 patients?
400 patients, 400 personnel.
Yes.
Of which 70% of the patients was severely mentally retarded.
Yes.
And yeah, as I say, we visited them every day, and it was a well-oiled machine. We were facility. We admitted a lot of patients from the outside. It was full at some stage, but I think it was a good place, and I loved working there. The patients, the stronger patients, went at least once a year on a holiday. We had an end-of-year function concert for them. We even had sports day once a year. So it was a fully functional hospital at that time, with the help of also a lot of competent management personnel.
Yes, continue.
Thank you, Maladi. Doctor, can you please tell the court, we had a discussion regarding the lunch times of the patients. Can you evolve or explain about that?
Yeah, they woke up in the morning at about 5 o'clock, and breakfast was given for the stronger patients in the hall. They got their medicine also with their breakfast. And at about 10 o'clock in the morning, we gave them tea and coffee and sandwiches or small cakes. 12 o'clock again, they had their lunch. And 3 o'clock again in the afternoon, they also had it again. They could have cold drink or they could have tea or coffee. And 5 o'clock in the afternoon, they had their main course, and then they also received their medication.
Was there anything specific regarding these patients and their appetite that you can explain to the court?
Sure. Now, they eat a lot. Our budget was very high for food. So, yeah, they liked their food. And, yeah, we when they need and they wanted, we gave it to them. The kitchen was basically always open. We had to control it, but we used to give them fruit also during the day. They had access to fruit during the day. They could just go and get some fruit and that.
Yes. Thank you, my lady. Doctor, you were called to testify today regarding the deceased Yakuza Stolz. Do you know the deceased?
Yes, I know him very well.
How is he known to you?
As a patient in Cullinan Care and Rehabilitation.
Yes. Thank you, my lady. According to his sister, Mr. Villiers, he was admitted at CCRC during 1997. Would he have been one of your patients since then?
That's correct.
Can you tell the court any specific knowledge that you have of Yaku specifically?
Yeah, Yaku was also one of the mental retarded patients, but he was one of the stronger patients. And but yeah, always friendly.
Yes.
Very active, very busy with his one skew eye. Yeah, and if I can remember correctly, he was always asking for a piece of paper or a pen so that he can draw something.
Thank you, my lady. Mr. Villiers testified yesterday that she brought Yaku to your practice on the 19th of September 2016. Do you recall that?
That is correct.
What date?
19th September, my lady. I apologize. Yeah, 19 September 2016. Thank you, my lady. Thank you, my lady. When Yaku was brought to your practice, did you have any reaction regarding the condition that he was in?
I was very shocked at that time. Yaku was always of thin build. I've never seen Yaku as thin as that I saw him that day.
That's okay. Yes.
Did you examine Yaku on that specific day?
Yes, I did.
Continue.
You made clinical notes on your findings regarding the examination. Is that correct?
That's correct.
Thank you, my lady. My lady, I would like to refer the court to page 3926 of the record.
Continue.
Dr. Lombard, can you please identify page number 3926 as well as the following page, page number 3927? Is that your clinical notes that you made on the date of his examination?
That's 100% correct.
Continue.
Is that your signature at the bottom of the notes and with the date allocated?
Correct.
19 September 2016.
That's correct.
On page 3926 is clinical notes, and 3927 is a diagram of a body of the patient. Can you please go through your notes, comparing it to the diagram so that the court can follow?
Okay, the clinical notes that I have at that day of the 19th September on 1:32 p.m. in the afternoon is that a patient was brought in with the history with severe vomiting and dehydration.
Just go slow.
Mr. Stalls was brought in with severe vomiting. And dehydration. He had scratch marks on his left shoulder, a scapular area. It's a bone in the upper part of your body. So
on his legs and
no, on the shoulder, on the scapula.
Okay.
There's a bone on the shoulder. There's two of them. The one was left, and that is just the area, but it was on the skin.
Okay.
Okay. And then there was in the center of the back at about T2, T5, it's the vertebrae. It's basically in the middle of the back. There was a hematoma. That I can assume that he was maybe assaulted.
Continue.
And then there was old lesions also on the back, but that was old lesions at about T12, so it's a little bit lower than where I said the hematoma
This was now there?
There was old wounds on the lower back, yeah, but that was not fresh wounds. And then there was a scratch mark on the right upper part of the right leg. And I assume he maybe fell on stairs or wherever, but it was also just scratch marks. And yeah, the general condition of the patient, he was very weak. He was really in a bad clinical condition. He was dehydrated. And with the vomiting, as I can remember, Sandra said he was about 2 or 3 days already. I gave him a Maxilon injection for the vomiting. And yeah, that is the general condition of the patient was in a horrific state, and there was definitely terrible negligence in medical treatment and looking after this patient.
Yes, Ms. Foster.
Thank you, my lady. So in general, you said glucose 11, what does that mean? After general, the
11.8, it is high. It's a mild form of diabetes.
Just hold it there. Continue.
Mr. Villiers testified that Yaku was not a diabetic. Is there any reason?
Yaku was not
a diabetic. It was not diabetic. Is there any reason what can be provided for the manifestation of this glucose or the mild form of diabetes?
It can be, I'm not sure if there's a genetic element in their family, but it can also be due to the dehydration, that there's an imbalance in the insulin and the glucose metabolism. But this is a non-insulin diabetic. The normal value for glucose is between 4 to 6.
Just hold it there. Continue.
Then you said on your notes that the patient has a thin build. Is there any way that you can indicate a weight limit that when you were the treating doctor of Yaku, what would be a normal weight for Yaku?
Approximately 60 kilograms.
How much?
60.
60.
Can you please explain to the court what your general examination determined that the patient is not Yaoundast? Is that the correct pronunciation? Can you explain that? The Yaoundast in your clinical notes. Can you please explain the word to the court?
Oh, that the patient jaundiced is that the patient is not yellow; it's jaundice.
It's not
yellow. If you look at a patient that has got a liver disease, the first sign in his eyes or on his nails is like it's like a yellow sign. Yeah, so it's jaundice. Yeah.
Oh, jaundice.
Jaundice. Yeah. Yes, my lady.
Yes, continue.
Thank you, my lady. Then it said that he's not anemic. What does that mean?
Also that it's usually it's a form of low iron in the blood or a shortage of red blood cells in the blood.
Yes.
The next term is not cyanosed. What does that mean?
Because his normal color, we usually look at the tongue. The normal color was pink, although it was dehydrated, the tongue at that moment. But cyanosis means that there's an oxygen shortage and the patient would be blue on the tongue and on the fingers, but mainly the tongue.
Yes, continue.
The last term in that sentence, and does not have clubbing. What does clubbing mean?
Clubbing is a condition in the finger nails, which have like an oval shape, and that is usually an indication of either hypoxia or loss of oxygen or liver disease or chronic infections.
Continue.
You also indicated in the next line that the patient has no sign of edema. Can you explain that to the court?
Edema is usually swelling of the feet, also the hands, and it's usually indicative of a
Just go slow, doctor.
edema.
Edema
Is a swelling as a collection of water due to heart failure, kidney failure, and respiratory failure.
Then has no lymphadenopathy.
Yeah, lymphadenopathy is lymph glands that's in specific areas of your body, and that's also usually indicative of a chronic infection.
Indicative
of a chronic infection, either bacterial or viral. But you can also have it in a condition where we call it lymphoma, which is a cancerous type of illness. But luckily, 90% of cases is infective.
And then has no pulmonary. I apologize, my lady.
Yes.
And then lastly, and has no pulmonary erythema. Can you please explain that to the court?
Palmar erythema is usually small bleedings in the hand palm, and that's also indicative of liver disease and other diseases, blood diseases. It's small little, it looks like small little reddish areas on the palmar of your hand.
Is indicative of?
Can be liver disease or blood disease.
Yes, proceed.
Thank you, my lady. Then regarding his blood pressure, 130/80, is that normal?
That's normal.
His temperature of 36.8.
That's normal.
And 20% dehydrated, is that normal?
No, that is not normal.
The temperature?
No. Dehydration. He had about 20%.
Well, the dehydration was not normal, eh? 20% you say it's not normal?
Yeah, I think it's abnormal if the patient is 20% dehydrated. You must remember your body, 80% of your body consists of water. If 20% of that water out of your system, it's basically a quarter of your water in your body. Then the patient will become very ill. Yeah.
Thank you. Ms. Foster?
Thank you, my lady. Respiratory chest is clinical clear, so there was no problem there.
There was absolutely no problem there.
Respiratory rate, 16 breaths a minute. Is that normal?
That's usually normal.
Yes.
Then cardiovascular examination of the cardiovascular system is entirely normal. No problem.
That's correct.
Then dermatology, skin patient has an abrasion, approximate size 30 by 30 millimeters. Is that correct?
That's correct. That is the one that's referred to on the back as the hematoma.
Oh, okay.
Do I then understand correctly that page 3927, the diagram, is an indication where all the abrasions that you have witnessed and the hematoma was indicated?
That's correct. That's correct.
Continue, Ms. Foster.
Thank you, my lady. So in summary, doctor, will I be correct to say that he had no other illnesses? He was actually in good health. The only problem was this extreme medical neglect and dehydration and his thinness. Is that correct?
Yes, I can only explain as I saw him that day, but previously, as I knew Yaku, he was always in good physical condition, although I haven't seen him for a while. But when they brought him in that day, I was severely shocked, and there was definitely severe negligence in medical treatment or prevention in him having the correct medical treatment in time.
Thank you, my lady. My lady, I will request the court at this stage to admit this document as Exhibit 03. Doctor, before I ask the court, do you have any objection if this is admitted as an exhibit into this record?
No, I do not.
Do you confirm the correctness of the contents thereof?
Yes.
Thank you, my lady. I will then request that the court mark it as Exhibit 03, if I'm not mistaken. That will be...
and Ms. Maru. The number of exhibits, and Mr. Van Bergen can also assist us. I think we were at all yesterday.
Yes, that's correct, my lady.
That's correct, my lady.
So should it be all three?
It deals with the same.
We have O1, which is the statement.
Yes.
Am I correct?
That's correct, my lady.
Well, lady, I'm not sure if the photographs were handed in as I can't recall now.
I think the photographs, let me just check, but I think they were handed in as Exhibit 02, if I'm not mistaken.
That's correct, my lady. Oh, this is L2. And just for information of the court, the numbered photographs has been uploaded to case lines under section 4.1.
Is there any objection to the handling of these clinical reports of Dr. Lombard?
May it please the court, my lady, no objection.
Just for the purpose of the record, the photos were handed in as they appear on page, is it section 412? As Exhibit 02. yesterday, and therefore the clinical records of Dr. Lombard are therefore handed in and marked Exhibit 03.
My lady, if I may.
Yes, you may assist.
When you speak, there's an echo with both myself and
You
Mary.
are having a problem. I can't hear you properly, Mr. Late. Something is not right.
When you speak, we experience an echo at our offices. I don't know whether somebody else also experienced it.
Can you hear Mr. Late?
My lady, I agree with Mr. Late. In your ladyship, there is an echo, but it is equally and I don't know.
But why are you also having the same problem? Does it come
My
from
lady?
this side?
Milady, can I suggest that Miss Foster mutes her mic when others are speaking? Because I think that might be the problem.
Miss Foster?
My lady, we are on the same mic. We don't have two separate devices in the mic and where I'm sitting. So
But we haven't been experiencing the same thing. I don't know. Can you hear me properly?
I can hear you properly. You don't have an echo. Mr. Light is breaking up now and then, and Mr. Van Bergen also broke up a bit, but I hear the call.
I think all of them have been breaking.
Yeah.
Maybe that is the problem we're experiencing. How do we get out of this? Either something is not right because we didn't experience this.
My lady, I'll go out and rejoin and you can see.
No, you are fine. In fact, you are fine now.
Thank you.
Can I hear Ms. Asim before I go to Mr. Wordbringer?
My lady, I think we all experience this problem.
But you're also fine now.
But now it seems to be fine. But I think it's because Miss Foster's device has been muted. So it's when it's not muted and somebody else is speaking that there is an echo.
Oh,
so
okay.
if she could just mute it each time somebody else is speaking, I think the problem will be resolved.
Is that fine with you, Miss Foster?
I also experienced that, my lady.
Yes, I think, yeah, you are fine. Okay. So just a second. Thank you, Ms. Foster. You may proceed. Let us proceed that way so that we shouldn't be experiencing the problem again. Thank you. Proceed, Ms. Foster. You are now muted. Yes. Mute yourself and proceed.
Thank you, my lady. May I then proceed?
Yes.
Doctor, on this specific day of the 19th of September, you also took photographs of the Yaku, is that correct?
That's correct.
My lady, these photographs has already been handed in as Exhibit 02. I would like to take the call to page number 37437.
Page
37437. The court will note that that is a new uploaded version that appears on the same as page number 3930. I have just added an A, B, C, D, E, F, and G on the photographs to make it easier to identify.
This is now 417.
Now, Malari, 37437 is the page with the, it's under section 412. I apologize. Indeed, that's correct, my lady.
This is 02.
That's correct.
Just a second. Okay.
So for record purposes, this is exactly the same page as page 3930. This is just one added with A, B, C, D, E, F, and G on there.
Can I just, for the purpose of the record, the photos of the injuries and the condition of the deceased Yakuza as they appeared on page 3927 have now been uploaded on page 37437 and have been properly marked as A, B, C, D, E, F, and G. This page is the page that has been previously handed in and marked Exhibit 02.
That is correct, man. Except the page number was 3930, if I'm not mistaken, but I stand to be corrected.
Is it 3? Yes, 3930, correct.
My lady?
Yes?
Ms. Foster was asked to mute when you are speaking, and she hasn't been doing that, so it's impossible to hear what you're saying. I just want to remind her that when she's not speaking, she needs to
yes.
mute.
Thank you very much, Mr.
Thank you.
Ms. Foster?
My lady, I sincerely apologize. We've been proceeding like this for months now. I never realized, I don't know why this now is a problem. I will do that. I didn't realize it's with the court as well. I apologize, Mr. Watpringle. I will indeed do that. So I will mute the time before.
Yes, please do that so that everybody can be captured. So I have to repeat what I've been saying. The photos of Yaku stalls the deceased in the case docket number 46 as taken by the sister Ms. De Villas and Dr. Lombard when he saw him on the 19th of September 2016 have been uploaded on Caseline and they've been previously handed in and marked Exhibit 02. These photos, after they've been properly identified and marked, have been uploaded again on Caseline on page 37437 under section 412. Thank you. You may then proceed.
Thank you, my lady. Doctor, can you please identify this document? Is this photos that you have taken? And I specifically refer to photo number A, B, C, and D.
Yeah, that's correct. Unfortunately, the C was not marked on the skin graft that I took, but A, B, and D is exactly what I marked on the clinical notes. Yeah.
Continue.
Do you recall photo number C that the mark indicated there? Do you recall that you saw that mark on that day?
I'm going to be honest, I can't recall that specific, but the evidence is there. But I can't recall that I specifically. I can't recall that lesion there.
Yes, continue.
Thank you, my lady. My lady, this thing, I'm finished with this specific document. It's already marked and handed in as Exhibit 02. I will then move on to the next subject. Doctor, on the specific day after you have examined Yaku's stools, Sandra de Villiers took him back to CCRC. Are you aware of that?
That's correct.
She testified that you provided her with a note to give to the sister or the nurse at CCRC. Is that correct?
That's correct. I did give her a letter.
I would like to direct the court to page number 30784. 30784. Doctor, can you please identify this document?
Yes, I can.
Please proceed.
Must I read it?
No, you can just first identify. Is this the note that you gave to Sandra de Villiers?
Yes, I notified it and I did give it to Sandra. And
the document is on your letterhead. It's dated Monday, September 1926.
That's correct.
It's regarding Yaku's stools.
That's correct.
And then you addressed it to the sister in charge. Can you please read out to the court what was the instructions that you provided to the sister in charge at CCRC?
That the above patient, Mr. Stalls, was evaluated by me and he was clinically dehydrated approximately 20% due to the vomiting. His general condition is deteriorating. His blood sugar is 11.8. And I treated him with some rehydrate. It's a medicine that we give for people that is dehydrated. And I gave him glucose medication. That's oral medication that I prescribed that the sister needs to give him. And then I asked the police to attend to this patient and treat him accordingly. If the vomiting continues, he needs to be admitted, please, with an intravenous infusion at a hospital or a facility, not specifically the hospital.
Yes,
Doctor, do you confirm the content of this document and do you have any objection if it's handed in and marked as an exhibit?
Yes, and I do not have any objection to hand it in.
Well, lady, I will then request the court to mark this as exhibit 04.
Is there any objection to the handing in of this document?
No objection, my lady.
May it please the court, my lady. No objection, sorry.
Thank you.
No objection, lady.
The letter from Dr. Lombard, as it appears on page 30784, is handed in and marked exhibit 04. Thank you.
Thank you, my lady. Did you have access to the post-mortem report of Yaku's stools?
Yes, I did.
My lady, I would like to direct the court to page number 4055. Doctor, can you please identify...
still going to get the document. Yes.
Doctor, can you please look at the document marked from page number 4055 to 4059? Is that the post-mortem that you had access to?
That's correct.
Continue.
Doctor, can you please tell the court, did you find any confirmation for your clinical findings in the post-mortem report?
Just what you think. Response?
I just want to make sure regarding the death certificate and my clinical findings on the day of what do you mean, or the diagnosis or the cause of death?
Now, regarding your clinical findings on the day of your examination.
Yeah, what I did find is, as I say, the patient was dehydrated, and when I weighed him, he was 40 kilograms.
Just a second. Yes, the patient is dehydrated and then his weight
40 kilograms.
Yes.
And what we can see on the photos, and if you look at the death...
Which photos now?
That's the photos that we gave in the exhibit.
Okay.
Yeah. You can definitely, even if it's a time after that, you can definitely see that there was also generalized muscle wasting and loss of subcutaneous adipose tissue, which is fat.
Are you reading from somewhere? Because you are too fast for me. Remember, we are not familiar with these medical terms.
Yes, I apologize.
My lady, may I interrupt the witness or directing? During consultation, you referred me specifically to paragraph 4 of the post-mortem that appears on page number 4056. Is that correct?
Just a second. Yes, I'm looking at paragraph 4. Yes, but I want to follow what he has been explaining now with regard to the weight and in relation to the photos that those photos that you have just referred to.
I agree, my lady. But
just leave him to explain, then you can direct us to paragraph 4. I'm in paragraph 4 of the post-mortem.
But that is where the witness is reading from.
Come again?
That is where the witness is reading from. So he's explaining his clinical notes according to paragraph 4.
Okay, let him do so, but I must follow what he's saying.
I understand, my lady.
Continue, doctor.
If you look
talking about the weight and you have just referred the court to the photos.
Yeah,
as we can see on the photos, and then
you can see on the photos, and you look at paragraph 4, there's a lot of similarity regarding the dehydration of the patient and the clinical...
Yes.
So it confirms the fact that he was severely dehydrated, and it's been going on for a few weeks already. And on the autopsy...
Just a second. Yes.
You can, on paragraph 4, you can see all the signs and all the clinical notes on the autopsy is exactly described as that the patient was dehydrated.
Yes.
I don't know if you want me to read it, to basically elaborate. It's just the sunken eyes is a definite clinical sign of severe dehydration. Generalized muscle wasting is severe sign of weight loss.
Just a second.
The skin turgor is decreased. It means that when you take a piece of the skin on your body and you pull it up, the normal patient, the skin will fall down in place, whereas a dehydrated patient will stay intact. It will look like a small mountain or a copy on the skin.
Okay.
And then the one thing also very important is the mucosal surface is dry in keeping with dehydration. So that is all indicative of severe dehydration.
Yes.
That's all that I have at the moment.
The last sentence in paragraph 4 is the injuries noted are in keeping with bed sores. Can you please explain to the court what is the cause of bed sores and what is bed sores?
Well, according to myself and as being a medical doctor, a patient should not have any bed sores. It's really poor nursing care when a patient do develop bed sores. It shows you that that patient has been lying in a bed, hasn't been turned, because according to bed sores, especially behind his legs or his feet, is that this patient was lying the whole time in one position. A patient does not need to have any form of bed sores in any hospital.
Yes, continue.
In your professional opinion, what could be the cause of the severe dehydration of Yaku?
Well, not getting enough food, not getting enough fluids, and just poor, not looking after the patient. Is either didn't eat, or he didn't get food, or he didn't get any liquids.
Yes.
This condition, is it something that will happen over a short period?
Not really. It can take about a week before they can really start having symptoms, but it's over a long period that this severe dehydration has occurred.
The evidence on record.
Just a second, Ms. Foster.
That can evolve into abscess formation, and because of the abscess of the lung collapse due to pressure. Anything else?
Okay. said I'm sounding better and there's no echo. So hopefully we're very okay to proceed.
I hope everything is fine. The witnesses want. When we took the T adjournment, I had asked you to explain what this both lungs are friable means. You were about to explain that?
Yes.
And I think Mr. van Bergen assisted you, if you may.
Yes, my lady. Thank you, Mr. van Bergen. Yeah, the normal consistency of a lung is like a sponge. And what this now means is that the lung is brittle. So it can be because of the infection that part of the tissue, basically when you put it in your hand, it's basically just vanished. Whereas a lung is a strong organ, and it's usually palpable like a soft sponge. Where this is just an indication that part of the lung tissue has basically died. There's no tissue left.
Continue, Ms. Foster.
Thank you, my lady. So, doctor, if the primary cause of death is indicated as pneumonia, can you please tell the court what role did the emaciated condition play in the primary cause of death?
Because of the general condition of the patient that was deteriorated and it was over a long period, the patient eventually, because of his immune system that was not effective, and he didn't basically have any defense mechanism by not eating or by not getting any food in, that it's natural that at some stage you will become ill, and then eventually you will have secondary complications, of which pneumonia is the most common illness that you will develop especially when you're bedridden or if you're not normally hydrated. So basically, when you're chronically ill, pneumonia is the first thing that's starting to develop, and then there will also be complications besides the pneumonia.
Yes.
As it pleases my lady, at this stage I would request that the post-mortem also be handed in. I understood from Mr. Lady can just confirm that there will be no objection and that Dr. Mabochwa will not be called to testify. So if we can hand this document in and mark it as an exhibit as 05, I'll really appreciate that.
Mr. Late?
My lady, he just moved offices. The computer he was in front of, camera does not work. You will assist the court shortly.
Okay.
My lady, Advocate Light requested me to confirm what Advocate Foster just said. So the document may be handed in.
So Dr. Mabuja is not coming to testify. Ms. Merritt, do you confirm that Dr. Mabuja won't be testifying? You are muted.
I apologize. Yes, my lady.
Postmortem report as it appears on page 40. Oh, before I do that, can I ask if there's any objection to the ending in of the post-mortem report?
May it please the court, my lady, no objection.
Thank you. The post-mortem report, as it appears on page 4055 on case line DR 1624 of 2016 by Dr. Mabuja, is handed in and marked Exhibit 05. Yes, Ms. Foster.
As a pleases.
My apologies for my absence, my lady. My computer is having ghosts today. I have to run between computers all the time. I ask for apology, ma'am.
Okay, no problem. Thank you, Ms. We have just handed in the post-mortem of Dr. Mabuja. It's now Exhibit 05, Mr. Late.
Thank you, my lady. That is great.
Okay, Ms. Foster.
As a good please, my lady. Doctor, I'm moving now to the last aspect of the evidence. Can you please tell the court if you also had access to the opinion drafted by Dr. Mabuja regarding this post-mortem report that was dated the 1st of June 2017?
That's correct.
My lady, I would like to refer the court then to page number 4061 and 4062.
Yes, I'm there.
Thank you, my lady. Doctor, I would like, during consultation, we spoke about or consulted regarding paragraph 4. Can you please read that out to in the record?
A medical legal post-mortem examination was performed by myself, S.S. Mabuja, on 26 October 2016. And the following is a brief overview of my findings. The deceased is emaciated. Features of pneumonia complicated by lung abscess and empyema, that is a lung abscess. Features of old cerebral infarct, that is basically like an old stroke in the brain. I concluded the cause and or the mechanism of death to have been following pneumonia, lung infection.
Yes.
Doctor, can you please explain to the court this paragraph? Does that fit in with your clinical view of Yakuza?
Just hold it there.
Are you talking about 4?
Yeah, paragraph 4.
Response?
That is correct, but I can go further by 5. What is more in place with my evidence? I do not have evidence of the pneumonia at my examination, but Dr. Mabuja said that he's unable to formulate an opinion regarding any inferences of negligence. So yeah, but otherwise the clinical can basically fit in with why Mr. Stalls has died.
Yes, and then about paragraph 5, what did you want to say?
No, Dr. Mabuja basically says that he's not in an opinion to formulate if there was any inference because of the diagnosis of pneumonia.
Yes.
And he said that the presiding judicial officer is better placed to decide on the matter. I don't know who he means by that.
So, Doctor, if I understand your evidence correctly, will you agree or disagree with paragraph 5?
I will agree with paragraph 5.
You will agree with paragraph 5?
I can agree with him that he made the diagnosis of pneumonia, but I disagree, and I say the patient was neglected.
Come again?
I can agree that the patient died of a pneumonia due to the autopsy, but in my opinion, he says he can't have any, he doesn't have any proof of negligence, whereas I have proof that this patient was severely neglected on the clinical examination that I have done.
You may proceed.
Thank you, my lady. Doctor, then in conclusion, will I be correct to say that although the primary factor of cause of death is stipulated as pneumonia?
That's correct.
The contributory factor was the neglect?
That's correct.
And the reason why you can say that is because you clinically observed Yaku on the 19th of September 2016.
That's correct.
You can link your clinical observations with paragraph 4 and paragraph 13 as indicated in the post-mortem report already handed in as Exhibit 05. Is that correct?
That's correct.
Yes.
Which is finally confirmed in paragraph 4A to D on the opinion drafted by Dr. Mabocha, which I will request the court to hand in as an exhibit after your answer.
I agree, it's correct.
Thank you, my lady. I will then request the court to also hand in the opinion by Dr. Mabocha, signed on the 1st of June 2017, to be handed in and marked Exhibit 06.
Thank you. Is there any objection to this?
Please, my lady, no objection.
The opinion of Dr. Mabucha, as it appears on page 4061 of case lines and dated the 1st of June 2017, is handed in and marked Exhibit 06. Thank you.
Mr. Light, do you want to say, my lady, if the court can just find out, does Mr. Light want to say, or can I conclude?
My lady, no, I'm just waiting for her to conclude.
Okay, thank you, my lady. That will conclude the evidence of Dr. Lombard. Thank you, my lady.
Thank you.
My lady, may I, as evidence leader, ask a few questions?
Yes, but I think the problem has started now. I don't know.
Yes, I think as soon as your ladyship leaves us, the echo will subside.
You want to? Okay, let me.
Just when you are muted, the problem will subside.
Yes, Mr. Late, you may continue.
Thank you. Thank you, Doctor. I think we are all at Edem that there was a neglect of the patient in one of the places where he had been kept. It was firstly in CCRC, then he moved to Siabadinga, then he moved back to CCRC, and then he went to Mamelodi Hospital. Which of these facilities, according to you and your timeline, in which of these facilities did the neglect take place?
Just hold it there, Doctor. Response?
Definitely CCRC.
Continue.
Did you at all communicate with any of the personnel at CCRC regarding the neglect of the deceased?
No, I did not. I just sent the letter.
Just hold it there. Continue.
Have you received any information about the response of the management at CCRC regarding your letter that you had sent?
What do you mean by management? The hospital management or the nursing management? Well, I didn't have any feedback. No, I didn't have anything.
So the
just hold it there. So you didn't receive any response to that letter from anybody?
Not at all.
Continue.
Not even from Mrs. de Villiers?
Come again?
No, Mrs. de Villiers.
Just a second. What about Mrs. de Villiers?
I asked, not even from Mrs. de Villiers, my lady?
Okay.
No, Mrs. de Villiers brought Yaku on that specific day. And basically bringing him into me with his illness, and I did my clinical examination, then I gave her the report, and she went back to the hospital. But from there, I only heard from Mrs. de Villiers a few years, 2 or 3 years after, when this case, basically, there was a case maker, but otherwise nobody has. The first thing that I heard is that there was a policeman that came in with a small written torn paper requesting the clinical notes of Yaku, and I absolutely refused to give it to him.
So Mrs. de Villiers never reported to you that they refused to obtain the medicine that you prescribed for the deceased? She never told you that?
No, I can't record that now. What she has said to me is that they didn't take him to the hospital at that day. That I know. But not of that day, yeah.
Just hold it there. Continue.
When you saw the deceased in such a bad state that you were actually shocked, why did you decide that he can return to CCRC and not being admitted to a proper hospital where he can receive proper care, whilst you were under the impression that he was neglected at CCRC?
Just a second. Just a second. Can you shorten the question, Mr. Wait?
When you examined the deceased, you were shocked. Is that correct? At this state of his health, and you also formed the opinion that he was neglected in care at CCRC.
That's correct.
Why did you allow him to be returned to CCRC and not having admitted in another hospital, whilst you were under the impression that he was not cared for?
Response?
My lady, on my letter, I never stated that he must be taken to a hospital. I stated that he must be put on an intravenous drip. Now, while I was working at Cullinan Care and Rehabilitation, and I can't speak for now, but when I worked there, we had 2 or 3 separate wards where patients could be admitted and put on an intravenous drip. And then from there on, I saw the patients every day. It's like a patient in a normal, I don't know if you've been to Cullinan Care and Rehabilitation, it's a huge facility. So we treated the patients there and we put them on drip or we give them antibiotics. The reason why I didn't get involved, they only came for an opinion because I felt, and what I've heard is there was no doctor working there at that time. I'm not 100% sure. There came in a doctor once a week. So, but I just feel my ethical thing is not getting involved in a hospital and taking over treatment from a hospital. I've always had a lot of confidence and respect for the personnel of CCRC, and I could believe that they would have done that. I saw some note that there was some area where they did put up a drip, but I can't get involved with the referring of a patient from an institution like CCRC to a secondary institution like Mamelodi or Steve Biko. I'm not authorized to do that.
Even if you feel that that patient was being maltreated at the facility where he came from?
Still, I believe that the present staff that works there, the professional nurses, are still able to monitor the patient for the first day or two, and then when necessary, hand him over to the doctor at the care centre and then refer him if they can't help him in Cullinan Care. It's just a primary facility. It's not a hospital function, but you can do primary medication a day or two, observe the patient, and then you refer. That's when I worked there. I can't speak for now.
When a patient is chronically vomiting, there must be a cause therefore. Is that correct?
That's correct.
Did you, when he was brought to you in September 2016, did you ascertain why he was vomiting?
Just already there. response.
I'm sorry, my lady, to interrupt. We still have a sound problem. Either Ms. Foster's device must be muted when your ladyship speaks, or Mr. Late speaks, or your ladyship's device has to be muted when your ladyship's not speaking, because Mr. Late is not going to come across on the record.
Yes.
Mr. Late speaks, there's an echo that prevents us hearing clearly what he's saying.
Thank you very much. Let me see if I mute myself.
Is that better now, Mr. Pringle?
Yes, as long as either the learned judge or, well, at the moment, both Ms. Foster's device and the judge's device are muted. But as long as one of them is muted when you speak, then there's no echo. But the moment both devices are unmuted, then your voice and any other person who speaks, I think their voice is muted. Your ladyship's muted currently.
To mute mine, please remind me, because it has not been happening with Ms. Foster's mic.
Thank you, Doctor. You can unmute yourself. Can you answer the question that I asked you?
Yes, at the moment in time, I couldn't detect a reason for him vomiting. But as I say, in further things, when I see on the autopsy he was bleeding, he had a massive peptic ulcer, so it could have been due to that. But at that moment in time, I didn't have anything. I was basically concentrated on the general health condition of the patient and the marks on the patient. But I couldn't say to you exactly at that moment in time that why he was vomiting.
You will agree that when a person has a peptic ulcer, a massive peptic ulcer, and is being treated in a medical facility, that normally intravenous feeding per drip is part of the treatment, and it's normally no per mouth. Is that correct? Are you unmuted?
That's correct. That's correct.
Yes. Is there any indication in the medical records that you have seen that he was not provided with a intravenous drip when he was taken back from your consulting rooms to CCRC?
At that specific time, but I did see on one of the notes that IV drip was, and it was it was running good. I'm not sure exactly what page it was. But
and it also showed that it was, sorry, excuse
no, he was put on I'm not sure that I can't confirm that, but it was definitely put on a drip, and the drip was running smoothly according to the that made the written notices.
And that notice also specified no per mouth, no per os. Is that correct?
I didn't see that. It's not necessary that you need to be no per os when you do get a drip. You can still have food, and if you still in having food or refuse to feed to eat, a nasogastric tube can be inserted, whereas proteins and everything can be given to you, especially when you vomit.
And if you have a massive septic ulcer, continuous vomiting is one of the signs thereof.
It's not the main sign. It's one of the signs, but it's not an absolute indication. The biggest symptoms, the largest symptoms, is mostly pain, epigastric discomfort,
yes,
nauseousness, and sometimes blood. But it's difficult. I'm not sure at that time when he was in CCSR if they send him for a gastroscopy or that they even know. It was only on the post-mortem that we saw that.
That you saw that.
Yeah.
but continuous vomiting can be a clear indication of a septic ulcer.
No.
Especially if you vomit blood.
Yeah, vomiting blood is usually indicative of a bleeding ulcer, but there are other causes also of consistent vomiting, like kidney failure or other diseases. But with a bleeding ulcer, it's usually a time span before you start having bleeding ulcers. And yeah, that is, but it's not a major. We see a lot of patients with ulcers, and especially bleeding ulcers, that not really vomiting.
Lady, you're muted.
Mr. van Bergen? Mr. van Bergen? Can you hear me?
Okay. Yes, thank you, my lady.
Oops.
Something is wrong with Mr. van Bergen?
I don't know if it's just me, but the sound.
Can anybody alert him of the problem?
Mr. van Bergen, can you hear me?
My lady, I can hear you now, but you were breaking up badly, as was Dr. Lombard. I don't know if it was just me or whether everybody had that difficulty.
Mr. van Bergen, I expect,
my lady,
I think it's from your side. I think it's from your side because you are the only one breaking up.
I'll go out and come back in. If I may perhaps just raise something while I am talking. My lady, Mr. Late referred to a septic ulcer, whereas I think Dr. Lombard referred to a peptic ulcer, if that can just be clarified. I'll go out and log back in.
Can we wait for him?
Yes, my lady. Thank you. I think he's back, my lady.
I am back, my lady.
Yes.
Yes, you may proceed, Mr. van Bergen. You wanted Mr. Late and the witness to clarify
yes.
The two issues.
Not sure,
yes. All right.
Yes, I'm not sure whether there was a misunderstanding on the part of one or the other, but I heard Dr. Lombard speaking of the possibility of a peptic ulcer, whereas Mr. Late referred to a septic ulcer, which are two distinct entities, if that could just be clarified.
I might have misheard, Doctor. Did you refer to a peptic ulcer?
I referred to a peptic ulcer, yeah.
Yeah, okay. Nevertheless, I don't want us to misunderstand each other. What I'm asking is not whether the vomiting can only be attributed to the peptic ulcer, I'm asking you whether vomiting is indicative if somebody has an peptic ulcer or a peptic ulcer.
It's one of the symptoms, but it's not indicative, but it's one of the symptoms. Yes.
One of the symptoms, yes.
Yeah.
So, and the vomiting could have caused the dehydration also.
Yes.
Is that correct?
Over a period of time.
As well as the emaciation. Sorry, you were muted. You could just answer again.
Yes.
Yes. Thank you. I have no further questions. Thank you, my lady.
Mr. Watbringle, do you have questions in cross-examination of the witness?
Lady, I have no questions for this witness. Thank you.
Thank you very much. Ms. Govender?
My lady, I have no questions for this witness, but I reserve our rights in the event that anything concerning my client becomes contentious.
Thank you. Ms. Rapina?
May it please the court, my lady, at this stage, no questions. Should it become necessary, I will forward a request to your ladyship to cross-examine, but not at this stage, my lady.
Thank you. Mr. van Bergen?
Thank you, my lady. I would like to pose some questions to Dr. Lombard, purely for clarification purposes. And the clarification, my lady, that I seek relates to the patient's clinical course from time of admission to the Mamelodi Regional Hospital. If I may proceed, my lady. May I proceed, my lady?
Yes, you may proceed.
Thank you, my lady. Dr. Lombard, good morning. My name is Harry van Bergen. I represent Life Esidimeni in these proceedings. As I indicated to her ladyship, there are just a few issues relating to the patient's course in the Mamelodi Regional Hospital, as it may or may not impact on the cause of death that I would like to hear your opinion on. If you would perhaps go to page 4010. And just tell me when you are there.
4010.
As your ladyship pleases.
It is here in front of me.
Thank you, Doctor. Doctor, you will see that this is a page on which there are two entries which appear to have been made. My lady, there is again feedback. I don't know if it's a problem on my side.
Mr. I don't know. There's something wrong, but I've muted myself.
Thank you. Let me try again, my lady. Doctor, you'll see there are two entries. They appear to have been made on the 3rd of October 2016, which is the date of the late Mr. Stolz's admission to the Mamelodi Regional Hospital. You will see that the first one is the time entry is 12:30, and it reads, a 51-year-old male, known diabetic on treatment, a mental health user from Cullinan. He is seen for vomiting and has been advised to see, and it looks like Dr. Mbara or Mbava, you see that, Doctor?
That's correct.
So it is clear that he was, the reason for admission was the vomiting, and I don't think there's any dispute about that.
No, I can't see the date of the admission. I can only see October 2016.
Yes, Doctor, if you move back to 4008.
The 3rd of October, okay. All right.
3rd October. And you will see the second entry has 3:10:16.
That's correct. Oh, yeah.
It would appear 2000 hours or sometime after 2000 hours. Now, if I may refer you to the second entry, the patient was taken over for days off, fully conscious and using all route care for further management. Would you agree, Doctor?
I'm going to stop you. You keep on breaking here. I see Miss Govender has been raising her hand, but because I'm muted, that's why you couldn't hear me. Miss Govender, did you want to also alert Mr. van Bergen that he was not audible? I think you're going to repeat what you have been saying regarding both entries. I don't know what could be wrong.
There's definitely something wrong with the system at Mrs. Foster's office. Because when the doctor's microphone is muted, you can hear Mr. van Bergen clearly. But when his microphone is on, then there's an echo. So if
even now you can see, I've now unmuted myself, but I can hear you properly. Yes. So it's not from our side.
No, it's definitely from Ms. Foster's side. If the doctor can just mute his microphone while the question is being asked, and then engage the microphone again when he answers, that will assist.
Would you do, Doctor?
Yes, my panel will do it. I'm not in control of the electronic stuff.
Okay.
Thank you, my lady. Doctor, I'll go back to the first entry. We have determined that the patient was admitted on the 3rd of October 2016. The first entry at 12:30 reads a 51-year-old male, known diabetic on treatment, a mental health user from Cullinan. He is seen for vomiting and has been advised to see Dr. Mbara or Mbava. So do you agree the admission was for management and treatment of his vomiting? Doctor, if you can just unmute yourself for the answer.
Yes.
Thank you, Doctor. If we can move to the second entry, the date is recorded as 3:10:16, and it appears to have been made at 2000 hours or shortly thereafter. And the entry reads, patient was taken over from day staff, fully conscious and breathing well on room air, wheeled to Ward B for further management. What I would like to inquire from you, Doctor, is whether you would agree that a patient who is breathing well on room air does not at face value at that stage appear to have a respiratory illness.
That is absolutely correct.
Thank you. So if you would then move to page 4017.
Just hold it there for me, please.
As your ladyship pleases.
Now the next is
4017, my lady.
Yes, you may proceed.
Thank you, my lady. Doctor, you will see that this page has the handwritten heading SOPD, which I assume indicates surgical outpatient department. Would you agree?
That's correct.
The note is also dated 3 October 2016 and the time 1435. This appears to be the notes made by the attending medical practitioner. Would you agree?
I can't agree on that because I don't have any names. It could be one of the sisters in the surgical OPD. I can't confirm that it was the doctor that wrote that.
Yes. Doctor, I'll take you through the entry, and perhaps from the nature of the entry, you could perhaps then express your opinion.
On the screen at the moment.
Beg your pardon?
I can only give the opinion that's on my screen at the moment. So if you can go down then.
Yes. The entry reads, ref, which is referred from Cullinan Rehab, constant vomiting, and then in quotation marks, coffee ground. Now, coffee ground vomiting is an indication of altered blood that is vomited up. Would you agree?
That's 100% correct.
Just hold it there, Mr. Van Bergen.
Thank you, my lady.
Yes.
Thank you, my lady. The next line, well, before we get to the next line, can you perhaps just explain to her ladyship what the term altered blood means?
Well, what I understand is when there was an ulcer and the bleeding has occurred for a time, and it is basically was collected into the stomach. That's what I understand under that.
Thank you, doctor.
What is that term? Alter?
Altered blood, my lady.
Altered blood.
Yes.
Okay.
So changed blood.
Come again?
In other words, changed blood. Blood that
altered, yes, altered. Correct, yes.
Red blood, it's been for a while. It's basically accumulation of old blood.
Oh, okay.
Thank you, doctor. The next line, there's a hashtag and then mental retardation. So that would just describe the late Mr. Stolz's mental condition. Then there is an abbreviation which appears to me to be O/E, meaning on examination. Would you agree?
Where are we now?
Okay, yes, that's correct. Where there's wasted, yeah.
Yes, my lady. There's an open line be under the words mental retardation, and then the next line, the abbreviation is O/E.
Okay, like a signature sort of.
It looks like a signature, but I read it as O/E for on examination.
Okay.
And then there is a plus sign with a circle around it and the word wasted. Doctor,
yes.
would that mean that this was a positive finding that the patient was wasted, as you had also described earlier in your evidence?
In his physical condition.
His physical condition.
That's correct. That's 100% correct.
And then,
what about his physical condition?
It was wasted, my lady.
Okay, was wasted.
Yes. Then the words mild dehydration.
Yes.
And below that, a negative sign with a circle around it and the word pallor, P-A-L-L-O-R, meaning that he was not pale. Would you agree, doctor?
That's 100% correct.
Yes.
The next entry reads chest hyphen or colon, clear. Do you see that?
Yes.
That to me implies that whoever examined the patient listened to his chest and did not detect any abnormal sounds in the chest.
That's correct.
So this would be an indication that at that stage the patient did not present with a respiratory infection or condition. Would you agree?
On that day, yes.
Yes. The next entry refers to his cardiovascular status, which I'm not going to address. Then his abdomen, I can't make out I think it says soft. And
Not
then
distended.
distended.
What? Standard?
Not distended. There's a negative sign, which means it's not, and then distended.
Is it distended?
Distended, my lady. D-I-S-T-E-N-T-E-D. Then 2 lines below that, there is an A with a circle around it, question mark, and then P-U-D. Doctor, would that be assessment? So that is the diagnosis that was arrived at that stage?
Yeah, the assessment, it's a query optic ulcer disease. I must say this clinical note is not very good, with all due respect.
Yes. Unfortunately, that's a problem that is not uncommon in most hospitals, doctor, in my experience.
It seems that it's peptic ulcer disease, the abbreviation now.
I would agree with you.
What is that?
My lady, there's a question mark and then
Yes,
P.
I am there, but I just wanted to get this abbreviation. It looks like it's a P, we're not sure.
Yeah,
P-U-D.
P-U-D, peptic ulcer disease.
Peptic ulcer
disease,
okay.
And then, doctor, there's a P with a circle around it, so that's the treatment plan. And it says IV line, intravenous line, and stat, looks like dose. I'm not sure of that last word.
It looks like dose.
Losec. It's
Losec.
It looks like Losec, yeah. It's a PPI which that we treat with for peptic ulcers. It looks like that, but he didn't give the dosage. But it looks like Losec.
That would make sense, doctor, in the light of the suspected peptic ulcer disease.
Yes.
So this would seem to address both the address both the dehydration and the suspected peptic ulcer disease. Would you agree?
Yeah, that's correct, yeah.
And then there is FBC, full blood count, U&E, urea and electrolytes, and looks like CRP, which is an infection marker. Would you agree? So those are blood tests that had to be performed.
That's correct.
And then it says review in casualty by on-call surgeon. And below that question mark, G-scope Friday. So it appears the intention was for the surgeon on call to see the patient and a possibility of a gastroscopy being performed on the Friday.
Correct.
And a gastroscopy is specifically to investigate the possibility of there being a peptic ulcer or not. You would agree?
That's correct.
There is a further note on the same page, and once again, it's not clear who did it, but there is, if you look at the signature in the right bottom corner, it says MBCHB. So this would have been a doctor who saw the patient. Would you agree?
Yes.
And this note was made at 1630, In the left-hand margin, it looks like casualty review. And the entry itself, HX, history as above. Then a hashtag, question mark, upper GIT bleed. That would be a gastrointestinal tract bleed. Would you agree?
Correct.
And hashtag mental retardation. So it appears that this medical practitioner agreed with the previous assessor that there was a suspected gastrointestinal bleed.
That's correct.
And we see that again in the right-hand margin. There's again the A with a circle around it, and it says metabolic acidosis. Can you perhaps just explain to Her Ladyship what metabolic acidosis is?
Yeah, this is totally a different concept than illness. It's basically when a person is either in a diabetic state where the sugar is on a high level and there's some kidney dysfunction, and then they develop metabolic acidosis. So it's basically a clinical symptoms that deter from maybe a diabetic complication or kidney disease.
Right, but we don't really have much more information than that statement.
Sorry, for lung disease can also, I see these hemoptysis also.
And can you explain to Her Ladyship what hemoptysis is?
It's when there's when you cough blood. When it comes out of the lung or the airway, is coughing up blood.
Right, you will see in this context, it's hemoptysis and then a 2 with a degree sign, which I take to be secondary to query PUD, peptic ulcer disease. So this examiner appears to have ascribed the hemoptysis to the possible presence of peptic ulcer disease. Would you agree that that is what
Let me just explain. Hemoptysis is when there's blood excreted from, usually from the esophagus or the stomach, but it can come from the lung also when you swallow it in. But that is exactly the fact where there's blood in basically your coughing or your gastric juices when you vomit up, yeah. But it does confirm peptic ulcer disease.
Yes. It does not appear as if a pulmonary cause was suspected by this practitioner.
Well, the P can stand for anything, pulmonary, but it looks like it's, as I say, these clinical notes is shocking.
Yeah,
you don't do abbreviations when you do this, everybody doesn't understand your abbreviations, so you should basically elaborate on what you mean there. When I saw this now for the first time, I thought maybe it was a pulmonary embolism or anything like that, a complication. But it looks like peptic ulcer disease.
Good. I would agree with you, Doctor. Doctor, if you would then please turn to page 4013.
Yes.
Doctor, you will see the date is 5 October 2016. This again appears to be an entry by a medical practitioner, as you will see from the signature. It looks like a doctor, could be Kumkani, I'm not sure, MBCHB. I was unable to find an entry for the 4th of October, so this seems to be the next consecutive medical entry made at 10:15, and the first line is hashtag mental retardation, query bedridden. Below that, hashtag admitted with dehydration and vomiting. So that again just sets the background why he was admitted. Then it seems like a C/O, which I would take complaining of, and it says feels better and hydration status improved. Would you agree?
what stands on the paper. I'm not sure about the feels better, what it means, how they communicated with him.
Yes.
But I agree with what stands on the paper, yes.
We can only deal with what we have on the paper. The treatment plan: continue with IV fluids, assist with feeding, and involve social worker. Would you agree? Doctor, would you agree that that is the plan? Yes. Thank you. Once again, there is no entry indicative of any concern about the presence of a pulmonary condition.
That's correct.
If we go to the next entry, the 6th of October, that's the next day. It's again a doctor with the abbreviation MBCHB. And the first entry, MR, which I assume is mental retardation. The second entry, dysphagia and vomiting. So can you explain to Her Ladyship what dysphagia is?
Dysphagia is a term that you can use if you can't swallow or if you have pain in swallowing.
Right. So that again goes back to, it appears to indicate the history with which he was admitted and the reason why he was admitted. Would you agree?
I agree.
Then there's an entry, sisters can't feed him. He vomits and does not swallow. So that would confirm your reference to dysphagia as painful swallowing. It appears that he had that difficulty and would not eat for that reason.
That's correct.
Then vital signs, blood pressure was 107/62. That is on the lower side of normal, would you agree?
Yeah, it's lower side of normal.
Heart rate looks like 70, I'm not clear.
70.
Yes. And it would seem the next entry is apyrexial, so he did not have a fever.
Correct.
The next entry, well hydrated. You would agree?
Yes.
So it would appear that by this time, dehydration had been successfully addressed.
Seems like that.
And then the plan, continue fluid resuscitation and then possible scope next week. The scope would be reference to the planned gastroscopy referred to earlier, not so.
That's correct.
And once again, nothing that is indicative of a pulmonary condition.
That's correct.
Doctor, if you could go then to page 4015.
Just a second for me.
As your ladyship pleases.
Page
4015, my lady.
pause 4015.
As your ladyship pleases.
Yes.
Doctor, this is an entry on the 10th of October 2016 by a Dr. C.P. Elsenbroek, who very helpfully had a stamp with his name on. You will note that I could not find an entry for the 9th of October, so there is one day that we have skipped as regards events. But on the 10th, the entry is made 51-year-old male, mental retardation and epilepsy. And there's an indication, a downward pointing arrow, and then GCS, and it looks like 10 out of 15. Would you agree?
Is he talking about the Glasgow
It appears to be the Glasgow Coma scale, 10 out of 15.
Yeah, that's correct. 10 out of 15, yeah.
So, Doctor, it would appear at this stage that there has been a change in the patient's condition, in that his mental alertness had become more impaired.
Drastic change, yeah, that's correct.
There is a reference in the next line, again, to coffee ground. Looks like, I'm guessing it's vomiting, but I can read coffee ground and then the next word I can't quite make out.
I also can't.
Yes, but then between the brackets is HE, and it looks
I think
like
we
10.
can't hear you now. I don't know.
My lady, if the doctor can perhaps just ensure that his microphone is switched off.
Yes, he's mute. He's on mute.
Thank you. My lady, is that better? Can you hear me now?
Let me also mute myself here. Continue.
Doctor, in that same line, between brackets, there is HB, and it looks like 10,2, which I assume is the hemoglobin level of the patient. Would you agree?
Correct, and it's normal.
The hemoglobin level gives an indication, or can give an indication, of whether there was excessive bleeding of any nature. Is that correct?
That's correct.
The next line, I can't make out if it's hypotension or hypertension, and then plus and then an upward arrow, and it looks like temp, which I assume is temperature on IVI.
Yeah, hypotension and increased in temp on IVI. Query sepsis.
So this is another indication, would you agree, Doctor, that there has been a turn for the worse in the late Mr. Salsa's condition?
That's correct.
Then below that, increased RR, which would be respiration rate. That's the tempo of his breathing, not so?
That's correct.
And that has become faster. And then question mark, aspiration pneumonia.
That's correct.
So it seems there was a concern that he may have vomited, and in the course of vomiting inhaled the substance that was vomited into his lungs.
That's correct.
And below that, it seems like on augmentin, but I'm guessing.
Just hold it there.
Augmentin, yeah. It doesn't say the dosage, or it probably was IV. It looks like augmentin.
Yes. And augmentin is a broad spectrum antibiotic, which would be indicated in suspected pneumonia.
Correct, that's correct.
And the next line, there's a hashtag, chronically ill, and I must confess I can't make out the next two words. Maybe you can assist.
No, I can't. Just a chronically ill. I think the last one is maybe alert, something alert. Metabolic alert.
Doctor, and I'm just guessing, but the second last word, could that be something to do with nebulization?
The second last word?
After the chronically ill, the next word.
It's difficult. I can't see it. No.
Doctor, let's rather not speculate. The next line, there's a question mark, and once again, I can't quite, it says something illness. Query underlying illness.
I can't read that, what the doctor wrote there.
So it seems there was a suspicion that there may be some other underlying illness.
Well, it seems like it, but I can't confirm it.
Yes. And then it looks like Dr. Mbava, not fit for scope.
Yes, his physical condition was not fit for a gastroscopy.
Yes. And then continue something IVI and AB.
You said his physical condition does not fit?
He was not physically fit to underwent a gastroscopy.
Oh, okay.
And then continue, and I can't make out the next entry, but then IVI plus AB, which I assume is antibiotics, plus O2, which is oxygen.
That's correct.
Thank you. Doctor, then the next entry on the same page, or perhaps before we go to that, just above Dr. Elsenbrook's signature, there's a P with a colon, and then Dr. It looks like Pizzi, to give medical opinion, MED opinion.
That's correct.
Then if we go to the next entry, 10-10-16 at 10:20, and at the top it says INT Med, which I assume is internal medicine.
We call them.
Just a minute, again.
That's correct.
Thank you. And that would be a physician normally.
That's correct.
It reads patient sleepy, query diazepam. Diazepam is a sedative drug. Is that correct?
Yes.
And post-ictal, so there was a suspicion that he may have had a stroke of some sorts.
That's correct.
Next, dried up hematemesis. Can you explain to her ladyship what hematemesis is?
It's basically that blooding that we were talking about, that he was vomiting, was basically dried. It was dry substance.
Right. Then the next entry looks bedridden, and then in brackets, a negative sign with a circle around it, bed sores. So it appears that at that stage there were not any bed sores present.
That's
Would
correct.
you agree?
I would agree.
And then wasted, and I'm not sure of that last line, that last word.
Just a second, Mr. Van Bergen. I didn't. Just a second. The issue about bed sores.
My lady, in the line that starts looks bedridden, there's a bracket and a negative sign with a, and the word bed sores and then close bracket. And the doctor confirms that that would mean that he did not have bed sores at that stage.
I forgot that I'm on mute. I wanted you to continue. You may proceed.
Thank you, my lady. Doctor, the next words, I think I've figured it out, wasted with contractures. Do you agree?
That's correct.
It continues in the next line of shoulders. So wasted and contractures of shoulders.
Yes.
Can you explain to the ladyship what contractures of the shoulders indicate?
It's basically when your shoulders is pulled to the back because of muscle wasting. And it can happen in legs and arms also.
Thank you, doctor. And then again, between brackets, threatening back and sacral sores. That appears to indicate that there were threatening bed sores forming on his back and over the sacrum at the bottom of his spinal column.
Yes, that's correct.
Which means that those threatening bed sores should have been attended to in order to prevent them from developing into bed sores.
That's correct.
The next line is pink, which I assume means that he was adequately oxygenated. Would you agree?
Agree.
Lungs clear, but in brackets tachypneic. That means that he had a fast respiration rate. He was breathing very fast.
That's correct.
Abdomen soft with normal bowel, it looks like BM, which I assume is bowel movement.
That's correct.
So that means that his abdomen did not present with any clear problems at that stage. Would you agree, Doctor?
Is muted, my lady.
Again, yeah, I agree.
Thank you, Doctor. And then the next line looks like chronic immobility with contractures.
That's correct.
And then the assessment, once again, query or question mark, peptic ulcer disease with bleeding. Post-ictal, possible aspiration pneumonia. That would be what one refers to as a differential diagnosis. Would you agree?
Yes, that's correct.
So those are the three possible conditions that the examining doctor suspected, and one of them being possible aspiration pneumonia.
I agree.
There then appears to be, then there's an RX treatment, C script, so the doctor provided a prescription, which we don't have, and then DW, which I assume is discuss with family. And I can't make out the next word, but it appears as if the patient's condition was discussed with the family.
That's right.
Just a second, I didn't pick that up.
The word is confirmed, my lady.
Come again?
I say the word my learned friend make out, I see it as confirmed.
I would agree with Mr. Late.
Family confirmed.
Yeah, DW, discussion with family confirmed.
Oh, yes, okay.
and then A/W. I'm not sure what that means. T/F, which I assume is a transfer to medical ward.
That's correct.
So it would seem that he was now going to be transferred from presumably the surgical ward to the medical ward.
That is correct.
Doctor, if I can just look at my notes. I was unable to find any additional medical as opposed to nursing entries, Doctor, but from this development in the patient's condition and the progression thereof, it would appear as if he improved on the treatment that he had been admitted with, but that round about the 10th of October, a week after his admission, he presented with signs and symptoms suspicious of aspiration pneumonia.
That is, I agree.
And that the bed sores appear to have developed subsequent to that date.
Just repeat, you cut out?
The bed sores appeared to have developed after that date, after the 10th of October.
I agree with that.
Doctor, would you agree that nosocomial infections, that is, infections acquired in hospital, is always a risk when a patient is admitted to hospital?
Very high risk.
So it may well be that he may have contracted either a nosocomial infection developing into pneumonia, or that because of inhaled vomitus, he developed aspiration pneumonia.
I think he developed aspiration pneumonia because of the inhalant of the vomiting.
Yes. Right. Doctor, thank you. Those are the questions that I wish to pose to you. Thank you, my lady.
Thank you, Mr. van Bergen. If I may just check. Ms. Hasim, would you have questions to this witness or your team?
Thank you, my lady. I have no questions for this witness.
Ms. Mjerere?
As please the court, my lady. I have no question to this witness.
Mr. Sibera's team?
As the court, please, my lady, we have no questions for this particular witness.
Thank you. Mr. Hutamo? Mr. Hutamo?
As the court pleases, my lady.
Mr. Hutamo?
As the court please, can the court hear? Can the court?
I can't hear you. That's why I keep on calling your name.
As the court please, my lady, we do not have questions
Thank
to
you.
the witness. Do not have questions.
Thank you, Mr. Hutamo. Ms. Seboko?
Afternoon, my lady. I have no questions for the doctor. Thank you.
Thank you, Ms. Ramaimela.
Thank you, my lady. We have no questions for the doctor.
Thanks,
As
Ms.
it is the court.
Matlape? Ms. Chaka?
No questions for the witness, my lady.
Ms. Maite?
May it please you, my lady, I have no questions for this witness.
Mr. Shavangu?
As the court pleases, my lady, I do have one or two questions, my lady, to the witness. Very short. Yes, my lady.
You may can we just hear? You are representing Siabadinga.
I'm representing Ms.
No, CCFC.
Yeah, the former CCFC CEO, Ms. Nyatlu. Thank you very much, my lady. Good afternoon, doctor.
Good afternoon.
I'm Advocate Chabangu. I'm representing Ms. Priscilla Nyatru, who was the CEO of CCRC up until the 4th of July 2016. Now, Doctor, I'll quickly lay a basis of my questions. It is only for the basis of clarification. A lot of my questions has been canvassed by my senior, as well as the people who asked before me by the, Leonard, Mr. Lloyd. Now, Doctor, you testified that you, at some point, you were the superintendent at CCRC, that's correct?
Ndo senda WhatsApp mbili vona vubuya nkhanne nga yin'we na ndo senda ichanga screenshot ndo senda bravo.
Please mute your mics. What is happening now? You are busy distracting our proceedings.
Yes, that is correct. I was.
Yes, and then just for purpose of clarification, Malady, I see you're going on. Just for purpose of clarification, by then, how many doctors did CCRC had when you were the superintendent?
I was the only doctor at CCR. I was a superintendent and I was a medical officer.
So you're the only doctor. And then you also testified that you examined the deceased Yakuza on the 19th of September 2016. That's correct?
That's correct.
By then, did one or maybe the family of Yakuza, in this case will be Miss Sandra, explain to you how many doctors were there at CCRC, or did you have any knowledge?
No, she didn't explain anything about doctors.
Thank you. So you also didn't know how many doctors was there at CCRC?
No, I don't know how the system at that stage was working, but when I was there, I was a superintendent and a medical officer.
Okay, thank you. I wanted to clarify that, but it's also possible that the status quo should have remained because you were the only doctor there by then.
Yeah, and as I say, they wanted a permanent position, and then I had to leave. But I'm not sure if they appointed additional doctors since I've left. But the majority of the CEOs was not medical officers. But I'm not sure if they appointed state doctors that visited Cullinan CRC at that stage once a week or every day. I'm not sure. I can't respond on that.
Okay, to assist you, Doctor, we have evidence that there was one doctor, Dr. Kinoshi, who come once in a week at CCRC.
Yeah, that can be correct, but as I don't know anything about it.
Okay, thank you, Doctor. I was just clarifying that one. And then furthermore, Doctor, when you were led by Ms. Foster, when you were asked, no, not by Ms. Foster, by the evidence leader, Mr. Lloyd, you were asked to indicate between
Mr. Late, not Light, Mr. Late.
Mr. Late, the evidence leader. Thank you, my lady. Apologies to Mr. Late. According between Siabadinga, CCRC, and Mamelodi, as to indicate where do you think that a medical negligence has occurred? And then you said definitely CCRC. Do you remember that?
Yeah, that I can remember, and I examined him while he was at CCRC.
Yes. So now I just want to clarify this in terms of time frames. So what the evidence leader did not put to you is what to give time frames. So when you say CCRC, what period were you referring to after you examined him?
I examined him. There was a time period that took long before he really got medical treatment at the hospital, not at Cullinan Care. But it's after my initial examination, yes.
That was after initial examination?
That's correct.
Thank you, Doctor. I have no further questions, my lady.
Ms. Mboweni?
May it please the court, my lady, I do not have any questions for the learned doctor.
Thank you. Mr. Manamela, are you there? Was Mr. Manamela at roll call?
No, Judge, he wasn't, but he did join in at a later stage.
When? Yesterday?
Today, Judge.
But he's not here now. I'm going to pass him. Mr. Profi?
As the court pleases, my lady, I have no questions for the doctor.
Thank you. Mr. Pichela?
Court pleases, with no questions for this witness, my lady.
Thank you. Anybody that I could have left out? Mr. Late?
I have no
Mr. Vesselo?
I have no question. Thank you, my lady.
Okay. Ms. Foster and the evidence leaders, is it time to excuse the witness?
I have no objection to excuse the witness, my lady.
My lady, if the court will allow me, I only have one question for the witness. I'm just trying to put myself into the picture. There we are. Okay, I only have one question, my lady, in re-examination for the witness. Doctor, all I want to know from you is, was his condition, the fact that he was mentally retarded, the fact that he was the reason why he was admitted, to why he should have been admitted or was admitted at the end of the day to a hospital?
No, I don't think the retardation was the reason. He was basically admitted as a normal patient. But because he comes from Cullinan Care and Rehab, he is a mentally retarded patient. But I think it was admitted because of absolute poor negligence and not looking after this patient. But I don't think it could have been any patient from any clinic, not specifically a mentally retarded patient.
Okay, but if you have to say why the reason was why Yakuza was admitted?
He was purely admitted because of dehydration, poor neglect, and general condition of his health. I think the time span to admit him in a hospital where you can get the best medical treatment, and especially at Mamelodi, it's an excellent hospital. But I think it was just the time span, the absolute neglect of treating the patient at that amount of time was really shameful. The general condition of the patient was very, very bad.
Thank you, my lady. I do not have any further questions. You are muted, my lady.
Yes, I just want to understand the last point. This neglect, do you still maintain what you said previously regarding CCRC?
I do.
Even despite the questions that were asked by Mr. Van Bergen regarding the issues raised, where at sometimes the issue of bed sores, it improved.
Yeah, I think that's a different issue, the hospitalization. The fact of the matter is the general condition of the patient deteriorated while he was in CCSR. And that contributed to being sick, having the epigastric ulcer, was treated there. Then a diagnosis. There's unfortunately no x-rays confirming the pneumonia. It was only on the medical legal report that he died of pneumonia. But I think in due course, from when I saw the patient, and maybe even beforehand, I'm not sure when he came from Esidimeni, but from that time until he was admitted in Mamelodi, yeah, it was really shocking, the general condition. And there's not rocket science. You can see on the photo, on the day of the examination, how that patient has been treated. And I was always so complimentary of Cullinan Care and Rehabilitation. It's an excellent facility. So I'm quite disappointed in what has happened to this patient. And not only Yaku, I think there was other patients also. But I can't comment on them.
Yes. Are there questions from the questions that this question that I've asked? Ms. Foster, I'm starting with you.
I'm finished. Thank you, my lady. I do not have any further questions.
Thank you. Anyone who has got questions from the questions that I've asked? In the absence of any questions, can I then excuse the witness, Miss? I think it's time to excuse the witness. Thank you. Thank you. Thank you, doctor, for availing yourself. This then ends your evidence. We hope it will assist us. Thank you very much. You are excused.
So my lady, he was muted. He was just thanking the court. I muted him. If you can just finish his sentence. I apologize.
Thank you for the opportunity to be a witness, my lady, and for the panel. And I hope the outcome decision will be the correct one. Thank you very much.
Thank you. Can we then take our lunch adjournment? And then we resume at 2 o'clock for the next witness.
As the court pleases.
May it please the court, my lady.
just before we start, if I may find out, this patient was at Mosero. Is it Mosero or Takalani? And this is the NGO whose owners or those who represent it have not secured legal representation.
My lady, we have spoken to Dr. Sikukuni. She provided me with one question which she has for this witness. So I'll include it in my examination.
Oh, okay. But in any event, if somebody comes and represent them, that person will be afforded an opportunity in case they can show a need to cross-examine the witness.
I agree, my lady.
Thank you, my lady. Yes, who's that?
This is Dr.
Sikukuni.
Dr. Sikukuni, my lady.
Okay, thank you very much. Nelisiwe, can you please administer the oath on the witness?
Thank you, Judge. Good afternoon, sir.
Good afternoon.
Please state your full names and surname for the record.
I am Mosou Paul Morule.
Mosou.
Mosou, M-O-S-O-U. M-O-S-O-U, my lady. Like Mosou, but now instead of
okay.
Mosou.
Mosou.
That's right, my lady.
Okay.
That's right, my lady.
Do you have, thank you, Judge. Do you have any objections to taking the prescribed oath?
I don't.
Do you swear that the evidence you're about to give is the truth, the whole truth, and nothing but the truth?
Yes, I do.
Please raise your right hand and say, "So help me God."
So help me God.
You are hereby sworn in. Thank you, Judge.
Thank you.
As a court pleases, my lady, this witness is going to testify pertaining to deceased number 96, Deborah Petla.
Yes, and is it only Deborah Petla?
Yes, my lady.
Okay.
Doctor, could you kindly place your qualification on a record, please?
It's MBCHB, which is Bachelor of Medicine, Bachelor of Surgery, obtained at the Medical University of Southern Africa in 1987. Certificate in Medicine and Law, obtained to the University of Pretoria and UNISA in 2003. Diploma in diploma in forensic medicine, obtained with the College of Medicine of Southern Africa in 2004. MBA in Healthcare Management, obtained with Regent College in 2007.
Come again, you're going to repeat that?
A Master of Business Administration.
Before we go to that, after the diploma, you mentioned something else?
No, I didn't, my lord.
No, after the diploma that you obtained in 2004?
Doctor, it's the MBA in Healthcare.
Yes. Management, my lord, yes.
This is the MBA in Healthcare?
My lady, yes.
Okay.
Excuse me, my lady, yeah.
Where is it from?
With the Regent College. It's here. It's based in Natal. Yes, this was in healthcare management, my lady.
Okay.
This was in 2007.
Mm-hmm.
And fellow of the forensic pathology, obtained to the College of Medicine of Southern Africa in 2013. Thank you, my lady.
Thank you.
Now, doctor, can you indicate what is your experience with the conducting of post-mortem examinations?
I'm going to ask you not to go too fast, Miss Merritt, for the sake of others and myself who are taking notes. Yes, continue.
I've got, this is my 29th year being in this service. Thank you, my lady.
Yes.
Thank you. Now, Doctor, if we go to your post-mortem examination, it's on page 6576 on case lines, my lady.
I see that.
Thank you, Doctor. Do you confirm that is the post-mortem report that you compiled pertaining to body number DK?
We all have that page already. Are we on the page?
6576, my lady.
Yes, I'm there myself. I'm asking the others.
Yes, my lady.
Okay, continue, Miss Merritt.
Thank you, my lady. Doctor, do you confirm this is the post-mortem report that you compiled pertaining to DK 521 of 2016?
Yes, I do.
Can you indicate whether there is any corrections which you want to make pertaining to the said report?
Yes, they are.
Can you please take us through
the corrections will be on page 6576. If we look at the Roman figure 2A, the person who pointed the body out to me there is Forensic Officer Mojalefa Maisa, M. Maisa, and not Senior Forensic Officer S. Nzeri. The next point of correction.
Just a second. Yes.
Will be on page 6577.
Just a moment, Doctor. Yes, we're on page 6577.
Under Roman figure 4, external appearance of the body and condition of the limbs. The first sentence there should read, the deceased was vomiting. So the letter was omitted.
The letter was omitted. Oh, you have just put in was here.
That's right, my lady. Same page under Roman figure 8, mouth, tongue, and pharynx. That's a second row from the bottom.
Yes.
The tongue is cyanosed, not cirrhosed. Cyanosed is CYANOST.
Just a second.
CYANOSED.
Oh, cyanosed.
Thank you, my lady. On page 6578. Second row.
Just a second. 6578. Yes.
Second row. Roman figure 11. That word should read oesophagus. It's running short of the GUS at the end.
Okay, the one, the first one. Okay.
That's right, my lady.
Esophagus.
Lumen. Same page, last row.
Come again?
On the same page, on the last row, Roman figure 15.
15.
Yes, my lady. I mean 18. Sorry, my lady.
Yes, that's why I'm asking you, because you said the last row. 18.
That's right, my lady. That should read copious amounts of watery.
Intestines.
That's right, my lady. That's not supposed to be water. That word there is watery, R-Y at the end, not in. Watery.
Amounts of watery fluid.
That's right, my lady.
Okay.
And 659.
Come again?
On page 6579. Third row, which is Roman figure 23.
The kidneys.
That's right, my lady. That word should read corticomedullary junction. There's a word junction missing.
Where is that?
After medullary. It's junction before full stop.
Just read the whole sentence so that, cortico. Okay, I see that.
Corticomedullary junction.
Junction, okay.
That's right, Madrid. And that is all, my lady.
Okay. Just a second, Miss Marriott. Yes, Mr. Merritt. Miss Merritt.
Thank you, my lady. Now, doctor, can you just indicate what was your finding or the cause of death according to your after your examination?
Thank you, my lady. Well, as said, the above mentioned postmortem examination here was conducted on an African lady who was reported to be 46-year-old. And who was reported to have demised on the 26th of March 2016 at 5:30 in the morning. This postmortem examination was conducted on the 31st of March, beginning at 9 o'clock at the Deep Blue Forensic Pathology Services facility. The cause of the death here was found to have been consistent with asphyxia due to aspiration of blood. In short, it is a generalized lack of oxygen due to aspiration of blood, or rather due to blood going into the airways and as such into the lungs. Thank you, my lady. Can I go on to...
Just a moment, doctor. Now, can you kindly indicate what caused this aspiration of blood?
Well, what the finding here was the aspiration of blood was associated with an injury in the upper airways, and to be exact, in the larynx, which is the upper part of the entrance of that's right, the uppermost part of the airways, below the throat, or in the region of the throat. An injury was found in that region. So it is assumed that there was bleeding from that area, and as such, blood just went down the airways to reach the lungs.
Now, doctor, according to your post-mortem report on page 6578, paragraph 17, there were foreign material found in the stomach of the deceased.
Paragraph?
Now, 17, Roman 17, my lady.
Yes.
Now, doctor, can these foreign objects cause the injury that you indicated was found in the upper airway?
It's a bit difficult to imagine these objects that were found in the stomach, namely having been plastics and pieces of brown papers. It may be difficult, but the pieces of brown paper, I wouldn't be able to tell before the digestive process or the biological breaking down of this to being the way it was, how hard it was before that. If it was hard enough, then maybe if it was hard enough, it could somehow have caused that. The other possibility.
You may proceed.
But under normal circumstances, it is not easy for plastic and paper to cause an injury of that nature. But this paper was brown, which may have been a box before. Then one wonders how hard it was.
Now,
the
if
other
you say,
possibility is.
Sorry, yes.
The other possibility would be the causative factor of that type of injury was not in the stomach at the time of examination.
At the time of examination?
Of the time of the postmortem examination, my lady.
Just hold it there, Miss Merritt. Continue.
Now, doctor, were you able to find anything that could have caused this injury after your examination?
Out of my examination? No, as I say, the only foreign bodies that are found in the body, in the stomach, were plastic and pieces of brown paper and nothing else. So as I was alluding to, it could be that if there is any other foreign body that could have caused this injury, it might well have been regurgitated or expelled out through the mouth.
Thank you.
Continue.
Now, doctor, you mentioned the correction on paragraph 8, page 6577 of your post-mortem examination. Can you just explain the meaning of cyanose?
Cyanose is a change in any part of the human, in this case, I'm going to refer to humans, in any part of human body where we normally know that our skin, depending on, among the other things, yes, but our skin is generally reddish or pinkish where there is enough blood supply. Where there is not enough blood supply, it can be pale. And where there is oxygen or lack of oxygen, it actually changes to purple, bluish purple tincture. And that type of change, which would be normally due to lack of or poor oxygen supply in the body, is referred to as cyanosis in a biological term. So meaning that it showed changes that were consistent with inadequate or lack of oxygen in circulation or in the body.
Thank you. You also made a correction, in paragraph 13, page 6578. There's a word, edematose and leopard skin appearance. Can you explain those two descriptions that you've mentioned?
If I'm getting you right, you're referring to paragraph 8.
13, page 6578.
Yes. Paragraph
13, Roman 13. It's the fourth from top.
13. I get that. Yeah, the right lung was noted to be oedematous. Oedematous means it was full of fluid, or it was more like watery. That is like in, a sponge that is, if you can imagine the sponge that is full of water. It is watery, or in biological terms, we will say that it is oedematous, meaning that the water content of that particular organ was visibly or physically increased. It showed leopard skin appearance. That is, now when you were looking at the lung from the outside, you would see patches that would resemble the skin of a leopard, that is against a background of the lung, which is pink, black, pinkish, blackish. You would see these blood spots appear like spots on a skin of a leopard. So that type of change we normally refer to as leopard skin appearance, with blood in the airways, meaning that a cross section or a cut lung would show where normally one would see that this is a hollow tube that would be containing air that would, under normal circumstances, not being able to see, because air cannot be seen, it's transparent. In this case, in that space that is normally occupied by air, there was blood. As I said before, this blood would normally have come from elsewhere, because that is not its normal space. Blood flows in the blood vessels and not in the airways.
Now, doctor, what is the explanation of the blood in this case?
The blood in this case, we should refer back to, there was an injury at the proximal or at the topmost part of the airways, which is an area in the front of the neck that some refer to as the Adam's apple. This bony-like structure that everyone has got in the front of the neck, that you touch on the middle front of the neck, below the chin, it is called the larynx. And it is the beginning of the airway from the throat. And there was an injury there, as referred before. And we know that every soft tissue injury, as we said, it was perforated. Every soft tissue injury would result in bleeding. And bleeding would have descended, or the blood would have flowed down the airway, because those parts that have just been referred to in the lungs are lower than the Adam's apple at the throat, or the larynx, which is the highest point. So fluid tends to flow from the highest to the lowest point. The other influence of that would be during your breathing in and out. As you inhale air comes through the throat, from the nose and mouth, past the throat into that area, the upper airway or the Adam's apple or larynx, down the trachea or windpipe to the lungs. And as the blood is is flowing down the tube, it will end up at the terminal parts of the airways, which are just underneath the skin, and it is blood. So it shows out on the outer skin, as referred to as leopard skin appearance of the outer part of the lung.
Thank you, doctor. Now, this blood, was that the cause of the person not being able to breathe?
Yeah, what happens is in the human body, or in the body of any other organism or animal, blood flows in the lungs, in the blood vessels. Air flows in the airways. If you get air in the blood vessels, it's likely to cause serious mishaps, as in what we normally refer to as air emboli in the blood vessels, which may be lethal. If you get fluid, like blood in the airways, is likely to be to lead to fatalities, as in aspiration of blood, or fluid, as in drowning. If you drown and fluid goes into the space, it doesn't belong there. So the lungs will not cope with that, and that often results in death. By the way, these changes here are exactly similar to the changes that the body experiences during drowning. In short, one could say that the lungs were drowned in blood.
Thank you, Doctor. Now, Doctor, I'm going to take you back to paragraph 17 on the same page, 6578. I just want to ask you, you said it contains 2 bottles of plastics. What is that? Or can you describe it further?
Right. When we say something is bottled up, we mean something is contained in, or it's contained in, or it's trapped in. So here were these plastics, which were rolled up and were the size of an adult fist, and were contained in the stomach. So the term to describe that would say it is bottled up plastic, because the way it was based in there, and it showed no sign of going beyond the stomach. So it was trapped in the stomach. And obviously, it could not go to the first part of the intestine called the duodenum, because there's a valve there. And it could not have gone again up into the valve at the opposite end that we call the esophagus, through the gastro or stomach or esophageal junction. So it was sitting in the stomach, meaning it was bottled up in the stomach.
Thank you, Doctor. Now, Doctor, if we go to page 6579, it's paragraph 23 pertaining to the kidneys. Is there any significance pertaining to the findings of the kidneys that you mentioned?
Well, here we're saying capsules the capsules stripped easily. They were pale, bled, and they showed a bled corticomedullary junction. These are the type of changes that we get in a condition that we call, there are many conditions that would cause this, but another of the conditions that may cause this is what we may call acute kidney injury. When you go through this kidney, say for instance in severe bleeding, or severe loss of fluid, or any other changes, acute changes that may physiologically lead to the injury of the kidney injury, you may get this. So this might well have been due to acute kidney injury, but the other possible cause of this is when you look at the period after death. This body is, or the deceased is reported to have demised on the 23rd of March, and the postmortem was only done on the 31st of March, which is about 26th to the 31st, it's about 5 days or so. So depending on the storage conditions of the body before the postmortem, they might have...
Sorry, Ms. Merritt, it looks like the judge has left the meeting.
Thank you.
She was frozen for a while. I think she's left.
Doctor, if you can just wait a moment.
Thank you.
My lady, you're muted.
Yes, I think I don't know what happened, but let's continue. Thank you. You had just referred the doctor to page 6579, paragraph, is it 23? 23, yes.
Thank you.
So you was trying to explain this thing concerning the kidneys.
Yes, my lady. The doctor was at the point where he explained pertaining to the refrigeration of the body. Did the court follow up to there?
Not yet, no. If we can just a second, I'm trying to access his line, but I'm almost there.
Thank you, my lady.
Six 659.
6579, my lady.
Yes, you may proceed.
Thank you. Apologies, doctor. Can you just explain again what is the significance of your findings pertaining to the kidneys in paragraph 23?
Thank you, Malay. Yeah, I had said that that type of changes in the kidneys we get in several conditions, which mostly lead to acute kidney injury. For instance, in severe bleeding, in metabolic injuries or physiological injuries, in poisonings, in certain poisonings, and the other cause may also be in as part of decomposition changes. The body undergoes decomposition. The longer the period after death, the more the changes the body undergo. And the bodies that are into decomposition may also present to such a picture. So one could not, specifically associate this with any of those multiple causes.
Thank you, doctor. Now, doctor, before I take you to your opinion, I just want to take you to another document first. My lady, it's on page 37431. It's
37431.
It's a periodical report received from Dr. Sekukune, dated the 6th of May 2013. That's pertaining to the deceased. If we can go to page 37432. Do you have that page? Now, Doctor, paragraph 2.
Is the doctor there?
I'm there, my lady.
Okay.
Or page 2, the first paragraph. Since admission, previous report, on the first line, it's indicated it's rubbish. Do you see that?
I do.
Now, doctor, would you find it strange to find foreign objects in the deceased's stomach if it seems that she has a history of eating rubbish?
No, I would not. I would not, and then I would also, point at one of my findings, which is in 6577. Page 6577.
That's back to the post-mortem report.
Yes, no, I'm still noting this. It's fine. Yes, doctor.
That would be paragraph number 6 in page 657. Intracranial contents. The brain was found to be small and atrophic. and it weighed 800 grams, meaning that this person had a small brain. And which measured below normal weight, which on average is around 1,000 grams. So such people would normally, most of the time, they are also found to be having small heads, small brain, which was also atrophic here, meaning that it was poorly developed, and they would be found to be mentally, I'm not sure I should say retarded, but yes, less developed, well developed mentally. So the behavior would, among the other things, be as described there as it's rubbish. They cannot distinguish most of the time between what's safe and what's not, what's unsafe, what's right and what's not wrong. Thank you, my lady.
Thank you.
Thank you. Now, Doctor, you've also compiled an opinion. We can find it on page 6599.
Yes, I did, my lady.
Thank you. It's basically similar to your post-mortem examination, except for the conclusion. Can you please read the conclusion into record?
According to the information given to me, the deceased was admitted and resident in a home for the mentally and physically handicapped. In my opinion, the findings at autopsy are suggestive of management or care of people with such incapacity not having been adequate, appropriate, and professional. It is therefore suggestive of medical negligence.
Now, Doctor, even with what I showed you pertaining to the periodical report, do you still maintain your conclusion?
I will still maintain that conclusion, because according to this report, if a person has a tendency of eating rubbish, then it means that there's got to be an increased level of supervision.
Continue, Ms. Merritt.
Thank you, my lady. I would then request that the post-mortem examination report be handed in as Exhibit P1.
Just a second. The post-mortem as Exhibit
P for Peter 1.
We are now at P, ne?
Yes, my lady.
This starts from 65762, 65
to page 6580, my lady.
Is there any objection to the handing in of the post-mortem report by Dr. Morule?
No objection, my lady.
Thank you. The post-mortem report in respect of Deborah Pesha, as compiled by Dr. Murule. This is DK 521 of 2016 as it appears on pages 6576 to 6580 on case line. It's handed in and marked Exhibit P1.
As the court pleases.
Yes, continue.
My lady, I will request that the opinion drafted by the doctor on page 6599 be handed in as P2.
Any objection?
May it please the court, my lady, no objection.
None, my
The
lady.
opinion by Dr. Morule is handed in and marked Exhibit P2. Thank you.
As the court pleases. And then the periodical report of Deborah Petla, dated the 6th of May 2013, be handed in as Exhibit P3, my lady. That's pages 37431 to 37435.
The periodical report in respect of the deceased Deborah Petla, dated the 6th of May 2013, as it appears on case line, pages 37431 to 37435. Before I hand it in, is there any objection to this?
May it please the court, my lady, no objection.
It is therefore handed in and marked Exhibit P3.
Thank you, my lady. Just to inform the court, the questions relating to the periodical report was the questions that was requested by Dr. Sikukuni as well.
Okay.
So therefore, I have no further questions for the witness.
Thank you very much.
Thank you, my lady.
Can I check Mr. Ward-Pringle, any cross-examination to the witness?
Thank you, lady. No cross-examination for this witness.
Thank you. Ms. Govender?
No cross-examination. Thank you, Ms. Lady.
Mr. Pina?
May it please the court, my lady, no questions at this stage.
Mr. van Bergen?
May it please you, my lady, no questions at this stage.
Ms. Hassim?
May it please the court, my lady, I have just a few questions for this witness.
Yes.
Good afternoon, Dr. Murule.
Good afternoon, ma'am.
My name is Advocate Hassim, and I represent families of the deceased in this inquest. Thank you for your testimony thus far. I just have a few questions for you of clarification in the main, Doctor. Doctor, the deceased died on 26 March 2016. And we see that from your post-mortem result. And in your post-mortem report, at page 6576, if I could just take you there, I just have one or two questions of clarity. Doctor, it's in relation to just what a layman is to understand by the cause of death. And you have recorded the cause of death as asphyxia due to aspiration of blood. And we've already gone through the details in the schedule of observations regarding what you found during the autopsy. When we talk about asphyxia, in layman's words, would would you say that that is suffocation?
It depends on one's understanding of what suffocation means. But suffocation is supposed to mean a lack of oxygen, yes, but in an environment. For instance, if you are put in a room or a tank or some container and then oxygen is taken out, there's a complete depletion of oxygen in your immediate environment. We say you suffocate because you are surrounded by an environment that's depleted of oxygen. But now asphyxia in this case is not in an environment, it's something that's happening from within the body itself, just to make it different from suffocation. It is experienced by the internal part of the body. That is the body internally not having oxygen, even if it's surrounded by an environment that's got enough oxygen. But internally it does not have. I'm not sure if I'm clear enough.
I understand. Let me put it this way. So it's lack of oxygen, and then you say due to aspiration of blood. So yes. The lack of oxygen was caused by, as you explained earlier, the presence of blood. I'm sorry, doctor. I think the judge has left us.
It does seem the judge. Yes, thank you.
Seconds. Yeah.
Yes, apologies. I don't know. Today my connection is giving me some problems. Okay. I think you were explaining asphyxia in relation to being in the body, to say that it is something where the body internally, you were explaining that it is surrounded by, then I got cut as you were explaining.
Yes, my lady, suffocation would be in relation to your surrounding. Mm-hmm. If you are in an environment that is depleted of oxygen, the deterioration or the pathology or the result of that is suffocation. Mm. Yes. But if within yourself and not within the environment, I mean within yourself, the inner part of it, anyway, yes. There is depletion of oxygen, which results in pathological changes, which may end up in a fatality. That is referred to asphyxia. That is mostly looked at by the amount of oxygen. Oxygen is transported in the blood. So if the if the oxygen in the blood is so depleted that there is depletion of the tissues itself, we call it the asphyxia. Mm. Yes, my lady.
Thank you. Continue, Ms. Asim.
May I please the court? Doctor, earlier you spoke about drowning, and as I understood it, you meant, and correct me if I'm wrong, that the lack of oxygen in this case was caused by the presence of blood in the airways. Is that correct?
Yes, you did understand me.
And the blood got into the airways.
That's right.
Did that get in, what caused the blood to get into the airways? Is that because of the perforated larynx?
Yes, one can only imagine that it was due to the perforation of the soft tissue of the larynx.
And what caused the perforation of the larynx was some object that was swallowed or attempted to be swallowed that was hard.
One can only imagine that because there was clearly an evidence of swallowing, of swallowing of foreign bodies that were picked up. But we don't know what else was swallowed or what else could have reached that upper part of the throat that was that did finally not end up in the body. The thing is, I do have photos of the deceased, which maybe I didn't, But what I remember from the photos is the area around the nostril and the mouth was quite bloody. That is, that part of the face was quite bloody, meaning that this blood would have come from elsewhere. There was an injury there, from which, if you imagine where the throat is, in the neck, some blood can be regurgitated or coughed out. Some would go down the body to reach where it reached, as evidence in the postmortem. So that injury could well have been that significant to have caused those changes, which in any case were seen. The lungs showed leopard skin appearance. That is, for every leopard skin spot that you see, you should know that there is supposed to have been air flowing in there, meant for the body, and not blood, or not fluid, or like water. Water as in drowning. Should have been air there.
I understand, Doctor. Thank you. Doctor, would you be able to provide the photographs that you had taken during the autopsy to the evidence leaders?
Photographs can be made available.
Thank you, Doctor. If I can just clarify, you say on the photographs show the evidence of blood around the nose. So that was externally. It was out on the face.
Yeah. There were those changes on the front of the face, or in the region of the mouth and nose.
Thank you. So the perforation of the larynx caused the blood, the bleeding. In your post-mortem report, you referred to 2 bottled up plastics, which are a size of a fist. Just for clarity, when you say there were 2 bottled up plastics, were they each the size of a fist?
They were actually intermingled and mixed, and it was actually difficult to separate them.
Yes.
But one didn't have to break anything to separate them. Finally, they were separated.
And can you tell us?
They were bottled up.
Yes. So what was the size of each?
Not all in all, they were the size of a fist.
Thank you. Doctor, I'd like to take you to a part of the record that you may not have in front of you. It's on case lines. And my colleague will display the page for you on the screen. It's page 21466.
My Lady Advocate Late will assist the witness pertaining to the case lines page. It's not needed to share on the...
I'm indebted to my colleagues.
2166.
21466, my lady.
214. Okay. Yes.
Do you have it, Doctor?
I remember seeing this. I might be having it somewhere. Oh, but I can read it on the computer. I do have it in front of me.
Okay. You'll see it's a document. It's a leave of absence form. Do you see that?
I do see this. I do see it, ma'am.
And it's a form that has been completed for the deceased Deborah Petler.
I do see it.
The expected, it appears that the expected commencement of leave was 23 March 2016, and the due date of return of 6 April 2016. And the important aspect for my question is on the next page, which is 21467. And on that page, Doctor, if you see what's written in under conditions of behavior which must be adhered to by the user, what's written in here, and I'll read it out for the record, it's user to be supervised all the time, no alcohol or drugs, medication to be given as prescribed, not left unattended.
I do see that.
So this, and it's signed by Dr. R. Wadvala. What we know, Doctor, is that the leave of absence never took place because the deceased was transferred from Life Esidimeni to Takalani Center on the 24th of March, 2016.
Okay.
My lady, again, for the record, if I can just take the court to the aspect of the record where we see the evidence of the transfer on the 24th of March. There's more than one, but I'll take you to just one part of the record, my lady.
Yes.
It begins on the next page, if you were to scroll down, it begins on the next page, 21468. And it's a series of photographs of SMSs.
Yes.
Relating to the deceased, which begins with an SMS that says, Petla Deborah is now placed at Takalani Center. And then it's a continuous message. And on the last page, which is 21471.
My lady?
Yes.
I want to object pertaining to the line of questioning. I do not see the relevance or the ability of this doctor to testify relating to the transfer of the deceased, except if my colleague can indicate where is she going with these questions.
Okay, thank you. Ms. Hasim?
My lady, I'm not asking the doctor to comment on the transfer. I'm merely, for the record, pointing out that the deceased was transferred on 24 March 2016. For the purposes of the record and for the assistance of the court, I'm taking the court really to these to this part of the record, which shows that the deceased was transferred on the 24th of March.
Yes, you had not yet asked the question. Ms. Marriott?
But, my lady, if I can just finish. My question is pertaining to the leave of absence form. So I haven't gotten to the question yet. I'm just putting my question in context. Thank you.
Ms. Marriott?
I will waiting for the question, my lady, to be asked.
Okay, thank you. Continue.
Thank you. So, doctor, what I'm saying is that this deceased was transferred on the 24th of March, 2016, to Takalani Center. She died 2 days later, 26th of March. 2 days later, on the 26th of March, 2016. But what is important is that the doctor at Esidimeni noted on the leave of absence form that she's not to be left unattended.
Again?
My apologies, my lady. The doctor noted that
she was put on absence of leave.
She didn't go on.
Yes, we are agreed that she didn't go because of the transfer, yes.
My question to the doctor is the part of the report where it says not to be left unattended. Would the doctor agree, given what he's testified and seen so far, that this is because of the mental disability of the deceased, including the fact that, as the periodical report said, she eats rubbish? Lady, there's someone speaking to the witness in the background, and I'm not sure what's being said.
What is happening there, if we may?
Nobody spoke in the background to the witness, my lady. There's a corridor behind this office. Somebody spoke in the corridor.
I can't hear you properly. What are you saying?
I said, my lady, somebody spoke in the corridor outside the office.
Oh, okay. All right. Thank you. Can we hear that question because there was an interruption, Ms. Hasim?
I'll repeat the question. Doctor, we saw the periodical report which said that this deceased eats rubbish. In this leave of absence form, the doctor says not to be left unattended. Would you agree that someone in the condition of the deceased, as we saw, is not to be left unattended because of the risk that she would eat and consume or try to consume things that she should not? Would you agree?
I would generally agree. I mean, if the person is said to be of the mental condition that is described in these things, they are of below average mental capacity. They would not be able to fend for themselves. They would not be able to, as I mentioned before, being under normal circumstances, being able to distinguish between right or wrong, or between safe and unsafe. So I would agree.
Thank you, Doctor. And on the periodical report, my learned friend, the evidence leader, took you to, and if we can just go back there to page 37431. My learned friend, the evidence leader, took you to the part of the periodical report on page 37432 where it's noted eats rubbish. And you've commented on that already. If I can just draw to your attention one or two other aspects that are recorded. The first is just below eats rubbish. it's noted totally dependent on staff for basic needs. And then it goes on to say unable to talk, unable to follow instructions. 37433, it continues in the middle of the page, unable to express herself, again, cannot talk, and again, totally dependent on staff. And this last one, totally dependent on staff, is noted after the question, should the user be discharged? And the box that is ticked is no. After having seen these notes, would you change your opinion as recorded in the addendum to your postmortem report?
Just a second. This is now 3743. 37433.
That's correct, my lady.
I have lost you a bit. What is my you mean would I change my conclusion as according to the opinion?
That's right, doctor.
No. I would not change my opinion based on the information that I've got.
Would you say that this information confirms the conclusion you came to?
The information is, if I understand it well, it refers to that the deceased was supposed to be under, under supervision or supervised care, and because of the mental condition. So I think what is being referred to in these notes that we have just been read and what I've picked up, they seem to be the same as my conclusion, unless if I'm missing something.
Thank you, Doctor. In the case docket, there's a statement that was taken from the deceased's mother. And the statement is, again, if I can just give you the reference, it's at page 6590.
Yes, continue.
Thank you, my lady. Doctor, it starts on page 6590, and it's a description of what from the mother's perspective took place when the deceased was transferred and when she got the call that her daughter had demised. And at page 6591, paragraph 7, the deceased mother says the following: I then went to Mosejo Takalani, in brackets, to try and get answers about the death of Deborah. I asked to see the place where she died. I was shown a small room, in brackets, the size a normal bedroom, close brackets, which the matron said the patients were kept there on arrival before being taken to the wards. The room looked like it was used a very long time ago because it was dirty, had spider webs and smelly. It had couches, in brackets, sofas, wooden cabinets with old files, and 2 beds. The room was behind the wards. And then she says, in her opinion, in paragraph 8, according to my observation and opinion, my daughter was kept in that room on arrival, and they forgot that she was there and that they neglected her. Would you agree that this evidence is consistent with lack of care and the deceased not being attended, not under close observation.
My lady, I want to object to this line of questioning.
Yes.
The doctor is a pathologist and he's testifying pertaining to that, my lady. There's no indication whether he can provide any assistance to the court regarding the line of questioning Advocate Hasim is asking him about.
Ms. Hasim?
May it please the court, my lady, this witness is a pathologist who's also given an opinion in relation to neglect. That's what the addendum is all about. And so since the witness has already given evidence and expressed an opinion on the care that was received by the deceased, I'm merely putting this to him to see whether it's consistent with his opinion. That's all.
Ms. Merritt? Are you there, Ms. Merritt?
Yes, thank you, my lady. It's still my submission, my lady, that this witness is not, or this question should not be asked to this witness.
Can I hear anyone before I rule on the matter? Anybody who wants to say something? Mr. Pina?
May it please the court, my lady, with all due respect to the evidence leader, my learned friend, the evidence leader, I would submit that my learned friend, Ms. Hasim, is within her rights to pose a question in this manner to the doctor, the witness. Although he is a pathologist, he ventured an opinion on regard of the standard of care that the deceased had received. And that is the issue that my learned friend Ms. Hasim is busy investigating, clearing up and obtaining clarification. So I would submit, my lady, that her question is founded, substantiated and admissible. May it please the court, my lady.
Thank you. Anybody else? I'm going to rule on the matter if there's no.
My lady, if I can just maybe add, it's my further submission that this is confirmation of evidence that's already on record. Advocate Hasim can argue that it's not necessary for the doctor to confirm this.
Okay. Ms. Hasim, what do you say to what Ms. Marriott has just said now?
My lady, the witness, again, I say the witness has given an opinion about the care that and the treatment that was meted out to this deceased. This is part of the context. And in the addendum, it says, based on the information that he received, this is part of the context, the information surrounding the death of the deceased.
Thank you.
Yes, I stand by my question.
The question is allowed. Continue.
Dr. Marule?
Thank you, my lady. I'm going to try and answer this in relation to my report.
Thank you.
In any case, the opinion here is based on care and not on the environment. It would be desirable for patients or people to be in a place that is considered safe and acceptable standards. But now, sometimes we often come across these places that might not necessarily be of that level.
Mr. Pichela, you have been quiet now. The witness has started. I've allowed the witness to testify. I don't know why you are raising your hand. Now it's going to disrupt the witness. Can I hear what you want to say? I just cannot understand. You don't.
I apologize, my lady. I was trying to wait for the witness to finish. Advocate Sibara says he's kicked out. He can't hear what the witness has to say, was he's kicked out of the proceeding. So I was just trying to relay that to the court.
Yes, Mr. Makani is there and he will get the record. Even on he can also listen on YouTube. Let's proceed. Thank you. Please lower your hand, Mr. Pichela. Apologies, doctor. You may continue.
You know what I'm trying to say here, it would be difficult, especially where we live. I mean, I'm just giving my opinion now. To find, especially with patients or generally members of the public or whatever, to find yourself in an environment that's conducive of safety and hygiene-wise and all these other things whenever you wish to. Sometimes one passes through this environment. So I would not easily use that environment, that room as described there, to say if the deceased was found at some stage in that environment, then it shows a decreased level of care. I think what I got from here at some stage was that the person who responded to the questioning was, this is sort of a room or a transit room where they pass during their admission, where they are kept temporarily at. So to me, according to my opinion, that's not the main thing. But the main thing is, if the patient or the deceased or anybody were to find themselves in such an environment, especially where somehow you are, say like in this case, it appears like the deceased was mentally retarded. That's where you need increased level of supervision, because you are in an environment that makes you easily vulnerable to your surroundings. But what I'm trying to say here is, if I understood well, if I'm to answer whether the deceased should have been in that environment or not, it would be difficult for me to say, but except that if you are in such an environment which is somehow unsafe, then there has to be an increased level of, attention to you.
Thank you, Doctor.
Thank you, my lady.
Thank you.
My lady, I have no further questions for the witness. Thank you, Doctor.
Thank you.
Ms. Minjerer?
Yes, please, the court, my lady. I have no questions for this witness.
Thank you.
For this witness.
Ms. Foster?
As the court pleases, my lady. Doctor, I just want to ask you one question. Can you please tell the court how old was the patient when she died? Did I read it correctly?
Just before, did you lay the outline?
My lady, it's just a clarification question on the postmortem. The deceased died when she was 46 years old. Is that correct?
The deceased died?
When she was 46 years old.
Mm-hmm.
Is that correct, Dr. Mulune?
Well, I would say reported she's 46 years old.
So she survived or was taken care of for 46 years. She was been able to survive and observed. So she was not placed in a position that she eat rubbish that led to a death. Would that be a fair assumption?
I missed your question. Would you repeat again?
I said for 46 years, people looked after this patient. So for 46 years, she was safe and she did not eat rubbish that could have led to her death. Is that correct?
I wouldn't say so, because there is a report.
There is just a second, Mr. Pichela. Just a second, Doctor. Mr. Pichela.
Yes, my lady.
Just a second, doctor. There is an objection here.
Lady, I have an issue with that question because it's too broad, it's too general. To say this person has been taken care of for 46 years without eating rubbish, when there is already an indication on record that this person has consumed, or there was a notation that this person must not be left alone, which to me presupposes that there is an indication that it might have happened before. In any event, this doctor will not be in a position to know the life of the victim in this instance. He only knows in as far as what has been written down and what he has been able to observe during the autopsy. So that question is quite broad and it's irrelevant. May it please you,
Ms. Foster? You are muted. I can't hear you.
I must thank Mr. Pislela because that is exactly my point. For 46 years, she did not die because she consumed rubbish. She was in a safe, the deduction one can make is she was safe enough and checked after and looked after. So she was not placed in a position where she consumed rubbish that led to her death prior to the age of 46. And that's what I put to the doctor.
I'm not sure if I follow. Okay.
So if I understand the question...
Just a second, doctor. We'll give you the opportunity. We have to deal with this now. Just a second. Mr. Watbringer, you want to say something?
Lady, there's a more fundamental difficulty with Ms. Foster's question.
Yes.
There's no opinion being expressed that the cause of death was the consumption of plastic or paper. To the contrary, the cause of death was some kind of injury which caused blood aspiration. And the doctor says he can only speculate as to what that was.
Aspiration of blood.
Aspiration of blood, correct. Thank you, my lady.
The cause of death was due to the fact that she consumed rubbish, and that is where the injury came from. Am I correct? The larynx was damaged because of the fact that she ate rubbish. That is what the doctor says.
Mr. Watbringer?
Lady, that's not what the doctor testified at all.
What the doctor said, yes.
No.
Can the doctor just clarify this so that we can pass this? Because sometimes these other things are going to confuse us. I mean, the cause of death is well explained. If you can touch that in relation to this plastic tube bottled what, just explain that, doctor, because now it's creating a confusion.
Well, the cause of death was found to be consistent with asphyxia due to aspiration of blood.
Yes.
And the deceased was found to be having a soft tissue injury of the upper end of the airways.
Which is the larynx.
Which is the larynx. And well, the patient the deceased was also found to have ingested foreign material.
Correct.
Like plastic and
the brown.
That's right. But as referred to before in this testimony, the plastic and the cardbox on the brown paper could not have been said to directly have caused the death. But I was saying that the death could have been caused by something else, which I did not find in the stomach contents.
Thank you.
But that caused the injury to the larynx and aspiration of blood.
Thank you very much, Doctor.
Do I understand?
That is clear, Miss Foster.
So if I understand you correctly, the rubbish caused the soft injury that was found on the larynx. Is that correct?
The larynx was sitting in an area where it caused no injury. If we can see, how do I put it? For this material to sit in the stomach, it didn't have to pass through the larynx. It passes through through a tube that is behind the larynx that is called the oesophagus.
Yes.
At the throat, there are two tubes. The throat opens up into two tubes as we go further down. The one in front, that is called this hard bone or cartilage that feels like bone in front, is the larynx. Behind that is the oesophagus. That's where these materials would have traveled.
Yes.
Yes. But during that swallowing, one does not know what else happened, or did it actually even happen during the swallowing, or whatever. I found plastic and brown paper in the lungs, in the stomach. But I also found an injury in the larynx, which most probably bled upwards through the mouth and nose, because, as we said, that surrounding area on the face was covered in blood, and also bled downwards into the lungs. And as I said, the lungs will not tolerate anything in those tubes other than air. The presence of anything, any fluid other than air there leads to death. If not, if there is no intervention.
Okay. Thank you, Miss. Thank you, Doctor. Miss Foster.
So, the relevance of the rubbish in the stomach is what? What will be the relevance of the rubbish in the stomach, the plastic that was found in the stomach?
The relevance of the lungs in the stomach is that the deceased consumed what was not expected to be consumed.
And she consumed that because there was negligence on the part of the people that was supposed to look after her.
If a person is known to be mentally retarded,
just a second, Mr. Pichela.
Lady, that now calls for a conclusion, and a legal conclusion that is the responsibility of the court to make. The facts are placed before the court will make that determination.
Yes,
now, to say that it's indicative of this or this, it could be indicative of anything. I can argue the whole day that alone is not indicative of negligence. So I object to that question, my lady, on that basis.
Ms. Foster?
My lady, I will put it to the doctor then that my argument at the end of the day will be that if this patient was not looked after, that she was there was negligence on the part of the people that looked after her, and due to that fact she consumed the rubbish, where you say it ultimately led to the bleeding, which ultimately led to the asphyxiation that caused the death of the
Yes, Ms. Marriott.
My lady, this question was already asked and answered pertaining to the conclusion on the opinion.
Thank you. Can I just, I think, yes, there's someone else? Oh, okay. I see the hand is down now. Can you respond to what Ms. Marriott has just said?
My lady, if that is so, why was there any objection to the fact that I asked the question in the first place? But I've put it to the doctor that I will argue that, because otherwise I don't understand why there was an objection raised if this question was already asked and answered.
But I think Mr. Pichela was coming differently. Yes, but it's up to you. Would you do you want to take this for?
I would love it if the doctor answers the question. He can only say yes or no, or he doesn't agree. I do not think there's anything wrong with what I put to the doctor. So if the court tells him that he's not allowed to answer, then I will leave it at that. But I have made that point to the doctor.
Yes, the point has been made, even if, I don't know, the doctor has explained himself, and then let's leave this. Thank you very much. If you want to take this to your argument, that's fine. We will hear what you want to say. Thank you. Do you have more questions to the witness?
I do not have any further questions. I do not have any further questions. Thank you, my lady.
Mr. Sibara, are you there? Or Mr. Makani?
As the court please, my lady, we have no questions for this particular witness at this stage.
Thank you. Mr. Hutambo?
As the court pleases, my lady, we do not have questions to the witness.
Thank you. Ms. Soboko? Ms. Soboko, are you there?
As the court pleases, I am, my lady. No questions for the doctor. Thank you, my lady.
Thank you. Ms. Ramaimela?
As the court pleases, my lady, no questions for the witness.
Thank you, Ms. Mahlapi. Ms. Koka?
May it please the court, my lady, I have no questions for the witness.
Ms. Maite?
May it please you, my lady, I too have no questions for the learned doctor.
Thank you. Is there anybody, Mr. Shabangu, are you there? As I know he asked to be excused. Mr. Piner, are you standing in on his behalf?
I'm standing in, my lady. Mr. Shabangu informed me that he has no questions for this witness.
Thank you. Ms. Mboweni?
Is the court.
May it please the court, my lady, I have no questions for this witness.
Thank you. Mr. Manamela, are you back or are you still not there? Nobody standing in for him. Mr. Profi?
No questions for the doctor, my lady.
Mr. Pichela?
May it please you, my lady. My lady, I just want to note that these witnesses are unrepresented. Ideally, if there were my clients.
I've made that at the beginning. I've noted that it is on record. And I've indicated, even after Miss Marriott has notified me that she has prepared a question that she took from Dr. Sekukuni, I indicated clearly that whoever at a stage where legal representation will be provided to her, I will afford that person the opportunity to cross-examine the witness if the witness can then be recalled, should that person deem it necessary to do so.
Then I believe that justice would be served, my lady. On that basis,
well aware of that, and this is what has been happening with your clients when we're proceeding in your absence. Thank you very much. Do you have questions to this witness, Mr. Pichela?
No, my lady.
Thank you.
My instructions are that there are no questions.
Thank you very much.
God pleases.
Mr. Vesalo?
I have no questions for the doctor, my lady.
Okay. Evidence leaders, is it time to excuse the witness? Ms. Marriott?
My lady, maybe the court can just inquire from Dr. Sekukuni whether she has any questions at this point in time.
Okay, I can just ask her, but immediately you told me that you had a question for her. Dr. Sekukuni, where are you?
Here.
Yes. Do you have questions to the witness?
I don't have any questions for now, my lady.
Okay, so you reserve your cross-examination?
Yes, for now, my lady.
Okay, thank you. I'm going to excuse the witness. Once you obtain legal representation, if there is a need, the witness can be recalled in case there is a need for further cross-examination of the witness by your legal representative. Thank you.
Thank you, my lady.
Thank you very much. Thank you, doctor. Thank you for your time. You are therefore excused.
As the court pleases, my lady.
Thank you.
My lady, we've arranged Stella Mofokeng, it's witness number 12 on the sequential list of proposed witnesses for tomorrow.
So is Stella Mofokeng alone tomorrow?
Yes, my lady.
Will she testify through an interpreter?
I'm sure Advocate Light will be able to assist the court pertaining to that. But
I thought he said you had secured 2 witnesses for tomorrow. Because what if we finish here? The other witness should be Nofili, number 19, if I'm not mistaken. The way he gave us the itinerary. Let me just... Can I quickly take my notes? Just a second. Oh, Stella Mufokeng, it's only for tomorrow. It's Wednesday, and then Mahlatsi will be available on Thursday. Okay, that's fine. So this is Stella Mufokeng tomorrow.
Yes, my lady.
Okay.
Should the interpreter be needed, she is available, my lady.
I'm just asking. I wanted to know whether she will be testifying through an interpreter.
I'm not sure, my lady. Advocate Light is in front of the other computer. Maybe he can assist.
Mr. Late?
My lady, I haven't received information that she will need an interpreter. But should she need one, the interpreter is available full-time.
Okay.
But I'll inform the courts in due time.
Okay. On that note, we adjourn the proceedings for tomorrow. Thank you very much.
Lady, could Ms. Marriott perhaps indicate the witness statements for tomorrow's witness? Sometimes there are additional statements that we're not aware of. If Ms. Marriott's still there.
Can we know Mr. Late and evidence leaders? Mr. Late and Ms. Marriott?
My lady, I will send an email. I haven't noted down the page numbers that's relevant for this witness. I'll send an email to my colleagues.
I'm indebted to my learned friend. Thank you, my lady.
Thank you. Thank you very much. The proceedings are adjourned until tomorrow morning.
May it please the court, my lady.
May it please the court.
May it please the court.
My lady.
As the court pleases.
As the court pleases.